Right, beta. So we are back, and I hope you had a nice lunch. Okay. Right, beta. So moving further, if we just take a look at the iliac fossa story, now herein, if we take a look at the indexing part of pediatric surgery first, right, beta. So what we have been doing, we have been talking about this cleft lip and palate, then the different swellings in the neck, then esophageal atresia, then in the epigastrium we talked about duodenal atresia, annular pancreas, and hypertrophic pyloric stenosis. In the right hypochondrium, we have talked about biliary atresia, choledochal cyst, and intussusception. In the lumbar region, we have talked about absent kidney, ectopic kidney, horseshoe, and polycystic kidney. And now we are moving down into the iliac fossas. Here we'll be talking about Meckel's diverticulum in the right iliac fossa and Hirschsprung in the left iliac fossa. Then we'll be talking about the hypogastric stories, the duplication of renal pelvis and ureter and ureterocele. Then we'll be talking about posterior urethral valve and hypospadias, and finally signing off with the undescended testis or cryptorchidism. So, beta G, if we see what is actually Meckel's diverticulum, so first of all we should understand that what actually diverticula means. A diverticula is simply an outpouching, right? For example, in these pictures, what you are seeing, these are the outpouchings from the sigmoid colon. These are sigmoid colon diverticulars. This is the outpouching seen in the pharynx area. So this is a pharyngeal diverticula, that is Zenker's diverticula. In the intestines, we find the diverticula something like this. Now, if this is the intestine, you are seeing there is a outpouching hanging like this. This is a congenital intestinal diverticula, the Meckel's diverticula. All these are images of Meckel's diverticula, right? Why these diverticulars occur, what are the different types of diverticulars? If we try to understand the entire story here, let us go into the intrauterine life first to understand what are congenital diverticulars. Broadly speaking, beta, there can be either a congenital diverticula or a acquired diverticula. Congenital is something which is present right from birth, and acquired will be something which is acquired later in life. Maybe due to the lifestyle habits, the acquired diverticulars can be seen. Now, regarding the congenital diverticulars, let us try to understand how these form. Look at me on the screen, beta, because this is the conceptual story, and this concept is something what the examiner wants to know from you. If you know the concept, your life will become really easy. Right. Now, if we go into the intrauterine life, beta, during intrauterine life, suppose I say that this is the intestine, and I say that this is the urinary bladder. What happens in the fetus? There are connections of the umbilicus with the intestine. There are connections of the umbilicus with the urinary bladder. This connection of umbilicus with the intestine is called as vitellointestinal duct or omphallomesenteric duct, and this connection of umbilicus with the bladder is called as allantois, which becomes the future urachus, right? All of you who are watching this session right now, beta, you do not have this connection right now. You do not have this connection right now. That means before we were born, before the birth, these connections, they obliterate. These connections, they completely obliterate so that right now in you, your intestine is not connected to your umbilicus and your bladder is also not connected to your umbilicus, right? Sometimes what can happen, if suppose this connection persists after birth, then you know whatever is the content inside here, whatever intestinal contents are present here, if this connection remains patent even after birth, then this saman, this content will start coming out from the umbilicus. And what is there in your intestine, beta? So whatever digested waste products are there, right? So suppose this is the fecal matter, then the small baby after birth will present with fecal discharge from the umbilicus, right? Or maybe the intestinal content, maybe some bilious discharge or something like that coming out from the baby's umbilicus, right? Since this will be a relationship between two people, the intestine and the umbilicus, so we'll call this as fistula. This will be a umbilical fecal fistula. The same story can happen with the urinary bladder also. If suppose I say that this connection persists after birth, then whatever is here will come out from the baby's umbilicus and the newborn baby will present with the urine coming out from the umbilicus. February 23, my dear doctors, when you're working in the hospital, if you see intestinal contents coming out from the newborn baby's umbilicus or urine coming out from the newborn baby's umbilicus, don't get panicked. This can be because this communication which used to be there during intrauterine life might have not closed and it is persisting. That is why the baby is presenting with something like this. This is called as umbilical fecal fistula and this will be called as umbilical urinary fistula, right? Sometimes what will happen, if suppose this connection is somewhat like this, that means only the umbilical end is patent, the intestinal end is closed. The intestinal end may have obliterated. Fine. Now what will come out from the baby's umbilicus, beta? There might be mucus. This would be lined by mucus. So mucus may come out from the baby's umbilicus. This is not a two-sided affair. This is just a one-sided affair with the skin. So one-sided affairs with the skin are called as sinus. This will be a umbilical sinus presenting with mucus coming out from the baby's umbilicus. You can also find this connection here. And then also the same story, the mucus would be coming out from the baby's umbilicus. This will also be called as umbilical sinus. Right. Now, sometimes what can happen, it is not the umbilical part, but it is the intestinal part which remains patent and the umbilical part closes. This what you are seeing, beta, this is a outpouching from the organ. Actually, it is somewhat like this. So can you appreciate this outpouching like this? This is what we call as diverticula. This is a congenital intestinal diverticula, also called as Meckel's diverticula, that is due to persistence of the intestinal end of the vitello-intestinal duct. This is Meckel's. The same way, beta, there is a possibility that here also this part of the allantois persist, this part persists, while this part has closed. So this will be called as a congenital urinary bladder diverticulum. So congenital diverticulus may be related to intestine, may be related to urinary bladder. Intestinal congenital diverticula is Meckel's. Bladder congenital diverticula is just a congenital bladder diverticulum. Right? Fine. Usually these congenital diverticulars, they have got all layers of the organ. For example, if we talk about the intestine, the different layers in the intestine, beta, the innermost layer is the mucosa, then there would be a submucosa, then there would be the muscle layer, and then there would be the serosa. So these are the different layers. Usually in congenital diverticulars, they contain all the layers. That means the story here would be somewhat like this: mucosa, submucosa, then the muscle layer, and then the serosa. So as you can see, this diverticula is also containing all the layers of this organ. A diverticula which is having all the layers of the organ is called as true diverticula, and a diverticula which does not have all the layers is called as false diverticula. Just like the true aneurysms and false aneurysms, true aneurysms have got all the layers of the artery, false aneurysm does not have all the layers of the artery. This congenital bladder diverticula will also be having all the layers of the urinary bladder, so this will also be called as a true diverticula, right? They are present right from the birth. Acquired diverticulas are occurring because of some or the other lifestyle issue. For example, acquired diverticulas are most often seen in the sigmoid colon. Now, if we just try to understand the story of acquired diverticulars, suppose I say, beta, that this is the cecum, then this is the ascending colon, this is the transverse colon, this is the descending colon, this is the sigmoid colon, this is the rectum, and this is the anal canal. Now, what can happen? One concept which we know, that जैसे जैसे उम्र बढ़ती है, इमारतें कमज़ोर होती हैं. As we are growing older, the walls and tissues are becoming weaker and weaker. So sometimes what can happen, if we imagine the Western countries like US, UK, Australia, these countries, if we look at their diet, their dietary habit does not include too much of fiber. If there is less fiber in diet, the peristalsis will not be proper in the intestine and the chances of constipation will be more. Right? So just imagine this gentleman who is having constipation. That means he is not passing the motions frequently. Maybe suppose he is constipated and he is passing the motion once in 4 days. What is going to happen? The fecal matter will start getting collected in the sigmoid colon, because sigmoid colon is the biggest reservoir. This rectum. Rectum and sigmoid colon, these are the reservoirs for fecal matter, out of which rectum is the biggest reservoir. Now what is going to happen if the fecal matter stays here? Then pressure in the proximal part will be high. If the pressure in this proximal part, sigmoid colon, is high, and if the wall of the sigmoid colon is weak, what will happen in elderly people? Then this high pressure will force the mucosa of the sigmoid colon to protrude outwards. Now suppose I say that this was the mucosal layer of the sigmoid colon. What is happening here? Because of high pressure in this area, this pressure is forcing this mucosa to create space between the muscles, and gradually this mucosa will protrude outwards. And what we can find in this case, there will be outpouchings of the mucosa or maybe the superficial submucosa from this area. And this is how the acquired diverticulars occur, right? These are false diverticulars because they do not contain all the layers. If we focus on another area, like this is the pharynx area. Here, this what you're seeing is the cricopharyngeal sphincter from where the esophagus starts. Now just imagine this is a sphincter. This is the narrowest part of the GIT. If the tone of this sphincter is high, that means if it creates a traffic jam type of situation, the pressure in the pharynx will be high. As the age is increasing, the valve would be becoming weaker and weaker, and also anatomically God has given a weakness already in pharynx in all of us in the form of a Killian's dehiscence, which is between the thyropharyngeus and cricopharyngeus muscle fibers of the inferior constrictor muscle. So there is already a weakness in this area. If the tone of this cricopharyngeal sphincter is tight, pressure more, high pressure will force the mucosa of the posterior wall of pharynx to protrude posteriorly, and that is how this Zenker's diverticulum occurs, right? So this Zenker's is also having only the mucosa or maybe the superficial submucosa, so this will also be a false diverticula. This is the story of acquired diverticulas, how we can find these acquired diverticulas. Now let us take a look. Umbilical fecal fistula. Umbilical fecal fistula, as we know, this is because of the patent vitellointestinal duct. The other name of this vitellointestinal duct is omphallo. Omphallo का मतलब होता है बेटा umbilicus. Omphallomesenteric duct. Omphallomesenteric duct. Umbilical urinary fistula. This is because of the patent allantois. Herein you can add these points beta, that umbilical fecal fistula baby will be presenting with intestinal contents coming out from the umbilicus in a newborn baby. Many a times beta, when you are examining these babies, you just put a cotton swab there at the umbilicus and you see that there is some yellow or greenish discharge at the umbilicus. You can try to smell that also, and when you smell that, you feel that this is fecal smell. So that is how we can come to know that, oh, there is a patent vitellointestinal duct, there is a fistula of the umbilicus with the intestine. Same way beta, umbilical urinary fistulas, you can find urine, or you can say a watery discharge from the umbilicus in a newborn baby. Umbilical sinus. We know what is a sinus. This is a one-sided affair with the skin. This is the patent umbilical end of either the vitellointestinal duct or the urachus. And here you will find mucus discharge from the umbilicus in a newborn baby. Mucus discharge from the umbilicus in a newborn baby. All these beta, the first two especially, the umbilical fecal fistula and umbilical urinary fistula, has been asked in the FMG exam in the last 5 exams. We had seen both the questions. Meckel's diverticulum. This is actually the patent intestinal end of vitellointestinal duct, and congenital urinary bladder diverticulum is the patent vesical end of the urachus or the allantois. Congenital diverticulars versus the acquired diverticulars beta. We can understand this story. The congenital diverticulars versus the acquired diverticulars. Congenital diverticulars, They are called as true diverticulars because they contain all layers of the organ. And the classical examples are Meckel's and congenital urinary diverticulum. They are present since birth. While acquired diverticulars, they are false diverticulars because they do not contain all the layers. They consist of only mucosa or superficial submucosa, and they are more commonly seen in elderly people. Congenital are present right since birth, while acquired are more often seen in elderly people. The classical examples are sigmoid colon diverticula, Zenker's diverticula, and acquired urinary bladder diverticula. This acquired urinary bladder diverticula beta, herein I would like to specify that 70-80 years old males, a common problem what we see is the benign prostatic hyperplasia. If suppose this is the bladder and urethra, we know there is a prostate gland situated next to the bladder neck, and 70-80 years old gentlemen, this prostate gland can increase in size. If the prostate enlarges, you can see what has happened to the diameter of the urethra. Urethra kitni patli ho gayi hai. Because of this, there is a traffic jam type of situation, and because of this traffic jam, you know the concept, the proximal people are going to get dilated, there would be stasis, infection and stone formation, UTI and stones can form. Also beta, the pressure in this part will increase, and high pressure in the bladder. If the wall of the bladder is weak, high pressure will force the bladder wall to move out. So that will result in an acquired urinary bladder diverticula. Just to explain the same concept. Now, if we talk about the Meckel's diverticulum here, what we were supposed to do in pediatric surgery, Meckel's diverticula, this what you are seeing, this is the outpouching from the intestine. You know why there is outpouching? Because it is the patent intestinal end of vitellointestinal duct. If we look at this area beta, this what you are seeing here, this what you are seeing here, all this area what you are seeing here, this particular thing, this is the mesentery. This mesentery is having the blood vessels which are supplying blood to the intestine. So look at the screen beta, this border of the intestine will be called as the mesenteric border, while the opposite border of the intestine, that means this border of the intestine, will be called as the anti-mesenteric border, right? So this will be the mesenteric border, while this will be the anti-mesenteric border. MCQ people ask you beta, Meckel's diverticula occur at which border? It is the anti-mesenteric border, anti-mesenteric border. And this Meckel's diverticula has its own blood supply. It follows the rule of two. There is a famous rule of two with this Meckel's diverticulum. This rule of two says, before we move on to rule of two, let us see what is written here. There is persistence of intestinal end of vitellointestinal duct or the omphallomesenteric duct. This is present on which border beta? Mesenteric or anti-mesenteric? Anti-mesenteric. Acha, tell me beta, mesenteric Meckel's diverticula, is it a congenital diverticula or acquired diverticula? It's a congenital diverticula. And congenital diverticula are true or false? They are true. Why they are true beta? Because they contain all layers of the intestine. Meckel's has its own blood supply and it follows the rule of two. Now this rule of two says that Meckel's is present in 2% of population. 2% of population, that means suppose we are sitting in a class of 100 people, then out of these 100 people, 2 of them would be fortunate who would have been provided this Meckel's by God, right? This is so common, but as a doctor, we don't see too often in practice, because even if the diverticula is there, they usually remain asymptomatic and they do not cause any problems to the patient throughout life. जिंदगी गुजर जाती है और एहसास भी नहीं होता कि हम वो थे जिनको ये था. Many times we come to know about measles at autopsy. जब पोस्टमार्टम होता है डेथ के बाद, तब पता चलता है कि भाई साहब को measles था. Right? So measles generally remain asymptomatic. They are very, very common, but they do not present to us commonly. Measles, if you take a look here, beta. Now in this, measles is 2 centimeters long. This is the length of measles. This is it is 2 inches long. It is 2 centimeters wide. This is the width of measles. So this is 2 centimeters wide. It is 2 inches long. And this is located approximately 2 feet from the ileocecal junction. This what you are seeing, beta, this is the ileocecal junction. So this is in centimeter. This is inches, and this is feet. 2 centimeter wide, 2 inches long, and 2 feet proximal to the ileocecal junction. 2 centimeter wide, 2 inches long, that is approximately 3 to 5 centimeter, and it is located 2 feet, that is 60 centimeters proximal to ileocecal junction. If the patient has to present, then usually it presents at around 2 years of age, and maximum 2% of patients can be symptomatic. These measles, they do contain heterotopic epithelium. Heterotopic means epithelium of somebody else would be present inside this measles. Somebody else means not the intestine, but maybe of some other part of GIT. Majority of the times it is the stomach epithelium which can be found in measles. Sometimes pancreatic, and sometimes even colonic epithelium can be seen in measles. Most commonly, it is the gastric epithelium which is seen in measles. Gastric means stomach lining in measles. Pancreatic and colonic epithelium can also be seen in measles. If measles is found in the hernial sac, sometimes what happens in inguinal hernias, which are occurring through the inguinal canal, if measles is also going along with the inguinal hernia, then such hernias are called as Litter's hernia. Litter's hernia. This was just a background story about measles. Just to have a quick recap, measles is a congenital diverticulum which is present right from birth. This is due to persistence of intestinal end of vitellointestinal duct or omphallomesenteric duct. Measles is found on the anti-mesenteric border. Measles has its own blood supply. It follows the rule of 2% of population, 2 centimeter wide, 2 inches long, 2 feet from the ileocecal junction. Presents at around 2 years of age. 2% of patients can be symptomatic. Measles consist of heterotopic epithelium. Most commonly stomach epithelium is present. However, pancreatic and colonic epithelium can also be present in measles. If measles goes into the inguinal hernia, then such a hernia is called as Litter's hernia. Usually measles is asymptomatic. If suppose the measles gets inflamed, it will cause acute inflammation of the measles, acute diverticulitis or measles diverticulitis, and then since this measles is almost located close to the appendix area, so acute appendicitis presentation, the same type of presentation will be there if measles is getting inflamed. So if measles becomes symptomatic, then it mimics the symptoms of acute appendicitis. Sometimes complications can occur in these Mecals. For example, as we are discussing, suppose this is the intestine, and here we know that there is a Mecals which is hanging down like this. What can happen? Most commonly, what complication we see in these diverticulas is they can bleed, and this blood will be going here. This blood will come out through the anus. So most common complication what we come across in Mecals is bleeding. However, sometimes what we can find, beta, that suppose these are the intestinal contents. If by chance these contents remain trapped inside the Mecals, these contents would be passing like this also, and these contents would also be going into the diverticula also. Now, if these contents stay in the diverticula, we know that whenever there is stasis, there are chances of party, and because of this, there may be acute inflammation of Mecals. And this acute inflammation, same Reubert tumor, Kallert-Dolor, that is what we call as diverticulitis. Sometimes if the pressure in the diverticula becomes too high, this mucosa can perforate, and that will be called as diverticular perforation. So diverticulitis and diverticular perforation can occur because there is presence of stomach epithelium in Mecals. Sometimes that stomach epithelium can ulcerate just like peptic ulcers. So peptic ulceration can be seen in Mecals. Sometimes intussusception can occur. Intussusception, we discuss the concept that whenever some part of the intestine becomes heavy, the peristalsis can force that part of the intestine to move into the adjacent part. I repeat this in Hindi, beta. इंटूससेप्शन के कॉन्सेप्ट में हमने देखा था कि जब भी इंटेस्टाइन का कोई हिस्सा भारी हो जाता है तो इंटेस्टाइन की पेरिस्टल्सिस की वजह से वो हिस्सा बाजू वाली के अंदर चला जाता है. Now, if somebody is having Mecals, then that part of the intestine will become heavy, and peristalsis can force that part of the intestine to ride into the adjacent part. So that is how intussusception can occur with Mecals. Sometimes, rarely, we can find intestinal obstruction also. Now, intestinal obstruction in Mecals, ideally, it is something which should not happen because this diverticula is not creating any traffic jam type of situation. If this is the diverticula, this is away from the lumen, so the contents would be moving nicely in the lumen like this, no traffic jam. So ideally, Mecals should not create intestinal obstruction. But sometimes what can happen, if suppose I say that this is the intestine, and from here, this is the diverticula which is hanging somewhat like this. Now we know that the other part of the vitellointestinal duct has obliterated. This obliterated part of the vitellointestinal duct, this may be present as a band inside. Just imagine, beta, that if you are having Mecals in your abdomen right now, and there is a band or a thread, धागा या रस्सी जैसी कोई चीज, if that is passing from the umbilicus towards your intestine in your abdomen, and if you try to turn on one side, suppose you're lying and you're turning your posture like this, there is a possibility that intestines can rotate around this band. ये जो धागा या रस्सी है, जब ये पेशेंट अपना पोस्चर चेंज करेगा तो हो सकता है जो पेट के अंदर इंटेस्टाइन है वो इस धागे में उलझ जाए, and that can lead to intestinal obstruction. So intestinal obstruction in Mecals is not because of the diverticula, but it is because of the band around which the intestines can rotate. So reason for intestinal obstruction in Mecals, it is due to band from the umbilicus to the apex of diverticula. Intestinal obstruction in Meckel's is due to a band from the umbilicus to the apex of diverticula. Right. How we can diagnose these Meckel's? There is a special investigation which is called as the Meckel scan. That is a radioisotope scan. And in this radioisotope scan, we actually give a radioisotope and we try to see if this can show us the Meckel's or not. These all images, beta, what you're seeing here, these all are the complete images of the abdomen. This is the complete image of the abdomen. And here we are just trying to look at some black shadow. We give an isotope that is 99 technetium per technetate, and we label it in such a way that this isotope is taken by the stomach epithelium wherever it is present in the abdomen. So when we give this isotope, obviously this isotope will be taken by the stomach epithelium. So we'll be able to see the stomach lining easily. Plus, if the stomach lining is present in the Meckel's, then we can see a black shadow in the lower abdomen. And this black shadow in the lower abdomen is actually suggesting that there is stomach lining present here. Normally the stomach is present in the upper abdomen, but if you find the stomach shadow in the lower abdomen, most likely there's a stomach lining present inside the Meckel's. And that is how this can be diagnostic for Meckel's. Once again, you can have a look, beta. You will see the stomach lining in the upper abdomen. If you are seeing that stomach lining in the lower abdomen also, that means the stomach lining is present inside the Meckel's. So this can be a confirmatory investigation for Meckel's diverticulum. This is a technetium 99 per technetate scan. It is also called as the Meckel scan. It is positive only when the diverticula contains associated ectopic gastric mucosa that is capable of uptake of the tracer. So investigation of choice for Meckel's is a Meckel scan. This is a radioisotope scan. This is technetium per technetate scan. Though other investigations which we can do for this terminal ileum, if we look at the contrast studies, beta, esophagus swallow, stomach meal, duodenum, jejunum, ileum meal follow through. So we can do a barium meal follow through for Meckel's. We can even do video capsule endoscopies. Now video capsule endoscopies, if you just try to focus that nowadays we are doing these endoscopies quite commonly. Suppose this is the esophagus, this is the stomach, this is the duodenum, this is the jejunum, this is the ileum, and here lies the ascending colon, the transverse colon, the descending colon, the sigmoid colon, the rectum, and the anal canal. Right. If suppose you are the endoscopist, just imagine that right now you are not holding the pen, but you are actually holding the endoscope. To pass this endoscope into the lumen of GIT, you have got only two options. Ya to upar se ya niche se, either from the mouth or from the anus. If you are passing the endoscope from the mouth, beta, you can very well understand that you can take it into the esophagus, you can take it into the stomach, you can take this into the duodenum, but it will be difficult for you to take this endoscope beyond this area. And here you can nicely see that the loops are actually coiled, and it will not be practically possible to take the endoscope like this. If you try to do endoscopy in this part of the intestine, then you may cause significant injuries and perforation. That is why when we are passing the endoscope from the mouth, we are usually able to see the esophagus, stomach and the duodenum area, but we are not able to see the jejunum and the ileum area. Same way, beta, if suppose I say that you are passing the endoscope from the anus, now with this you will be able to pass this endoscope into the anus rectum, you will be able to pass this into the sigmoid colon, you will be able to pass this into the descending colon, you will be able to pass this in the transverse colon, you will be able to pass this in the ascending colon and the cecum. But again, here there is a ileocecal valve, and you will not be able to pass this endoscope into this ileum. That means if you are doing endoscopy in the GI tract, upper GI, lower GI. Upper GI, you can go up to the duodenum. Lower GI, you can go up to the cecum. That means this area of jejunum and ileum, it is difficult to see by endoscopy. And endoscopy is actually going into the lumen. So endoscopy would be a wonderful investigation for the pathologies in the lumen of the intestine, or pathologies which are originating from the innermost layer of GIT, that is mucosa. So endoscopy would be perfect to see the lumen or the mucosal pathologies of GIT, except the jejunum and ileum area. That is why for jejunum and ileum area, we are not having any endoscopy as such. We are still going ahead with CECT to diagnose problems in these areas. While for these areas, we are doing endoscopy commonly. Same way for this area, we are doing the endoscopy commonly. Somebody told the surgeons that, okay, agreed that you cannot pass the endoscope into the jejunum and ileum, but if I give you option that I create a special type of capsule, for example, if I create a capsule here, this capsule suppose is having a camera inside. Now, if there is a camera inside the capsule, and if you give this capsule to this patient to swallow, the patient will swallow this capsule. The camera in the capsule can be programmed to take pictures at regular intervals. So just imagine that this patient has taken the capsule, and now the capsule has been programmed to take pictures at regular intervals. Suppose the capsule has been programmed to take pictures at every 3 seconds. Then every 3 seconds there is a photograph taken. If the capsule remains inside the stomach for 2 to 3 hours, then every 3 seconds the stomach is getting picturized, and the stomach is continuously changing the clothes, sometimes suit, sometimes t-shirts, sometimes shirts, and like that. And the stomach is also getting confused that, oh my God, how important, how VIP I am, that I'm getting clicked every 3 seconds, right? Okay. Now this capsule will be moving forwards, and the capsule would be taking pictures at other areas. The capsule is coming here, and by chance suppose we want to see the Meckel's, and Meckel suppose comes to know that there is somebody who is coming to take the photograph of Meckel's, then Meckel's would also be absolutely ready to get clicked. Now let us just imagine that if suppose here is the Meckel's, and Meckel's is ready to face this photograph, the capsule is coming, there is a possibility that this capsule is coming like this, and within say 2 seconds the capsule moves out. Meckel's, who was eagerly waiting to get clicked, if suppose the capsule immediately moves out of this area, then the Meckel's will not be clicked, and the Meckel's would get disappointed. Oh my God, all this effort was done to click my photograph and this capsule did not click my photograph. My goodness. Moral of the story, beta. We can do capsule endoscopy, but there can be advantages and disadvantages. We might miss the lesion for which we are actually trying to carry out the study. That is why video capsule endoscopy is not the recommended method to study, right? Also, sometimes what we have seen, beta, if suppose by chance there is intestinal obstruction, suppose I say there is a traffic jam in the intestine here, and you are giving the capsule, then you can understand that this capsule will get stuck at this level. And many times, earlier days, we were using battery operated capsules. And you can imagine if the capsule gets stuck here and there's a battery inside. So the battery continuously is discharging, and sometimes it can even explode inside the abdomen. There have been cases reported on Google where we have seen the explosions in these capsules, especially if you do this capsule endoscopy in intestinal obstruction cases, right? So just to give you a glimpse about this video capsule endoscopy, this is something which is not the recommended method. Okay. Now, how do we approach these patients, or what should be the treatment for Meckel's? The confirmatory investigation is a radioisotope scan. If the patient is asymptomatic, no treatment is required. I think by now we are absolutely clear in our minds that we are the doctors. We are supposed to treat the patients, not the papers. अगर पेशेंट को कोई तकलीफ नहीं है तो हमको भी कोई तकलीफ नहीं होनी चाहिए, right? So if Meckel's is asymptomatic, no treatment is required. But if the patient presents with symptoms or complications, then we have to do something for this Meckel's. Now, what's something we can do for Meckel's? For that, let us try to see if the patient is symptomatic or there are complications. Then what we can do is, suppose I say that this is the intestine, right? This, what you are seeing, beta, this is the mesentery which is supplying blood to the intestine. And here what we are seeing, the blue color, that is the diverticula which is hanging from the intestine. Now it actually depends on the mouth of this diverticula, whether the mouth of the diverticula is narrow or wide. For example, if I say that, suppose I make the intestine like this, okay, so that there is no confusion. This is the intestine, and suppose now I am drawing the diverticula. Suppose the diverticula is something like this. Now, if the mouth of the diverticula is narrow, then what you can do is, you can just take a stapler. We are commonly using staplers in surgery nowadays. Staplers, the stationary stapler you have seen for pinning, right? So the surgical staplers, they also have got pins inside. The difference between a stationary stapler and a surgical stapler. Surgical stapler, which is used inside the body, also has a knife. That means when we are firing the surgical stapler inside the body and you press the button, the knife comes out, it chops, and then the pins come out and they seal. So a surgical stapler used inside the body cuts and sutures at the same time. Katta bhi hai, jodta bhi hai. If you are using a surgical stapler here, beta, then you can fire the surgical stapler in such a way that it will cut and suture at the same time. And that is how we can remove these narrow mouth diverticulas, and we'll find some two pins here like this. And this is not going to cause too much compromise in the lumen of the intestine. But if suppose I say that the diverticula is wide mouth, if suppose the diverticula is wide mouth, maybe something like this. Now, if this is the diverticula And if you want to do a diverticulectomy in this particular case, beta, then you might have to fire that stapler somewhat like this. And if you fire the stapler somewhat like this, then it will cut and suture. And after this suturing, what lumen you would be having would be somewhat like this. So herein you can very well understand that this is going to cause significant narrowing in the lumen of the intestine, right? So for a wide mouth diverticula, we cannot do a diverticulectomy. A better option for a wide mouth diverticula is, it's better that you do a resection of the segment of intestine. You can chop this part of the intestine like this. Once you chop it off, what you will be left with, beta? You will be left with this, and you will be left with this. Now you have to simply join this part with this part. That means you do a resection of the segment of intestine bearing the mecals and then do a end-to-end anastomosis. That is the treatment for symptomatic complicated wide mouth Meckel's diverticulars, right? So if the patient is asymptomatic, kuch nahi karna. If the patient is symptomatic or complicated, depends whether it's a narrow mouth or a wide mouth. Narrow mouth, you can do diverticulectomy. But a wide mouth Meckel's, you have to remove the segment of the intestine which is bearing the Meckel's and then do end-to-end anastomosis of the remaining normal intestine. Right, beta. So if the patient is symptomatic or there are complications, then what we are going to do, if it is a narrow mouth Meckel's, then we do a diverticulectomy. If it is a narrow mouth Meckel's, then we do a diverticulectomy. We remove this diverticula. If it is a wide mouth Meckel's, then it is better to resection of segment of intestine bearing the Meckel's with end-to-end anastomosis. With end-to-end anastomosis. Usually staplers are preferred for Meckel's surgery. So I hope, beta, this Meckel's is nicely clear in your minds. Moving further from this Meckel's, let's take a look on the left iliac fossa side, and there is a disease called as Hirschsprung disease. The other name of this Hirschsprung is congenital megacolon or congenital aganglionosis. This is basically absence of ganglion cells in the nerve plexus. In adult surgery, beta, we'll be discussing a disease called as achalasia cardia. There also there will be absence of ganglion cells, right? Okay. But that is something which we see in adults. What actually happens if we try to understand this? Most commonly, we find this disease in the rectosigmoid area. where rectum is always involved. Let us try to understand the story. This pink what we are seeing, beta, this is the mesentery, and this would be having the blood vessels which would be supplying blood to the intestine that we know about. Right? Now, what will happen if we just try to take a look in the muscle layer? The different layers, the mucosa, submucosa, muscle, serosa. Now here, beta, in the muscle layer, suppose this what I am drawing is the muscle layer. There are nerve plexuses, there are ganglion cells, and if everything is normal, these nerve plexuses, the motor nerve plexus especially, is responsible for the peristaltic movements. But sometimes what happens, beta, there may be absence of ganglion cells in these nerve plexus, most commonly involving the rectosigmoid area. Now suppose I say that if I look at these nerve plexus, if there are ganglion cells which are present all over, suppose the ganglion cells are present all over, but they are absent only in a very small area, versus the ganglion cells are present all over but they are absent in a large area. Okay, suppose the blue color what you are seeing are the ganglion cells. Now what will happen? The area where you are seeing the blue color, that will be having the peristalsis, but this area where there are no ganglion cells, this area will not be having any peristalsis. Here this area will not be having any peristalsis. Now what actually happens? If suppose only a short segment is aganglionic, then only this part will not be having the peristalsis. That means when the fecal matter is coming, suppose the fecal matter is coming here like this, there is nice peristalsis, and the force of this peristalsis may be sufficient to push this fecal matter out, and this fecal matter may be going out because there is only a very small segment which is aganglionic. As this baby will be growing older and older in childhood, when the length of the aganglionic segment also tries to increase, at that point of time the child may suffer from constipation. Now if the child suffers from constipation, obviously we try to diagnose this problem. Initially we try to treat these children with dietary modification, but if the story is something like this, the dietary modifications are not going to help, and then we might think that this child is having Hirschsprung disease. To make the diagnosis of this Hirschsprung disease, what we can do, beta, we can simply put something from below, some instrument from below. You can just put some instrument from below, maybe a biopsy instrument, and you just take a biopsy from this area. As soon as you take a biopsy from this area and you give this to the pathologist, pathologist will tell you that there are absence of ganglion cells in the specimen, and that will confirm the Hirschsprung disease. Agreed that this biopsy will tell us that this is a case of Hirschsprung disease. But biopsy will not be able to tell us what is the actual length of the aganglionic segment. Because now when you have to treat this baby, you might have to remove that aganglionic segment and do the anastomosis of the normal segments. to know what is the length of this aganglionic segment. Herein, this part would be having the peristalsis. Okay, we are just trying to figure out this area, right? Okay. Which investigation can tell us the length of aganglionic segment? For that, we can do a barium enema. Like here, what you're doing, beta, you have passed a flatus tube. This is a Mota catheter, which you can put in the anus. And then through this tube, you can push the contrast up. This is the aganglionic segment. This narrow segment, what you're seeing, beta, this is the aganglionic segment. This is a area where the peristalsis is not there. So there might be fecal impaction seen here, and proximal to this, there would be dilatation. This dilated part is actually normal, having normal ganglion cells, but this contracted part is the aganglionic or the pathological part, right? We can do some operations and treat this condition. We can even do manometry, anorectal manometry in these situations, because whenever there will be a traffic jam, the proximal people are going to get dilated and the pressure in the proximal part will increase. So we can do manometry to assess the pressures in the rectum, right? And then we can do some operations where we treat this aganglionic segment. Another story, beta, if we try to understand this particular story, now herein, the ganglion cells are present here. But here in this area, there are no ganglion cells. What will happen? As soon as the baby is born, if a long segment is aganglionic, the peristalsis would be coming only up to this point. And now, whatever fecal matter is here, whatever fecal matter is coming here, the force of peristalsis is not going to be sufficient to force this fecal matter to negotiate through such a long aganglionic segment. So now this fecal matter will not pass through such a long aganglionic segment, and all this fecal matter is going to get collected here. Now if all the fecal matter is going to get collected in this particular area in a newborn baby, you can very well understand that all the proximal people are going to get dilated, and this proximal colon will get grossly distended in the newborn baby. This colon is going to get grossly distended in this newborn baby, and there will definitely be a risk of perforation of this colon. If you take a look at one of the images here, just have a look at this baby. Can you appreciate how the abdomen is grossly distended in this newborn baby? That is because of a complete traffic jam in the rectosigmoid area, where the fecal matter has impacted and the proximal colon has got distended, carrying the risk of rupture. Now this is an emergency situation, beta. And to relieve this emergency, see, we have been trying to understand the concept of traffic jam at so many places in surgery, beta. We discussed that how the pressures can increase in different areas of the body. We talked about the intracranial pressures, if you remember. We talked about the arterial pressures. We talked about the venous pressures. And herein, we talked about the different traffic jam situations in the biliary channels, how the proximal biliary channels are dilated. We talked about the pressures in the intestine. In this emergency situation, if there is a complete traffic jam in the colon, you know that this can cause perforation in the proximal colon. What you can do is, you have to relieve the pressure so that the rupture of colon does not occur. You can do a small operation in 5 minutes in this baby. 5 minute का एक छोटा सा operation करेंगे बेटा. You will make a small cut in the abdomen of this baby. You'll just make a small cut here, and you will put your thumb and the index finger inside the peritoneal cavity, there will be a grossly distended transverse colon lying here. You will just bring the transverse colon out on the abdominal wall. As the transverse colon is out on the abdominal wall, you will just fix this transverse colon on the abdominal wall with some small sutures, and then you shift the baby out of the operation theater. Outside the operation theater, you can just make a small cut on the transverse colon. As soon as you make a small cut on this transverse colon, whatever is the masala inside, all that masala will come out, right? That means this is going to relieve the pressure. You are communicating the colon outside. This is called as colostomy. Colostomy. In all traffic jam situations in the large intestine, beta, to release the pressure from the colon, we can simply do colostomy, proximal colostomies. So this is how we manage these babies in emergency. Sometimes we might come across some different type of situations, as you're seeing here on the screen. You just carefully take a look. This is the large intestine, what you're seeing, beta. And we had to chop the entire large intestine out of this patient. In this picture, you can see a narrow segment and a dilated segment. The narrow segment is actually the affected aganglionic Hirschsprung segment, and the proximal segment, what you're seeing, the dilated segment, that actually developed multiple ischemic areas. Multiple impending perforations were there, for which we had to take out the entire colon of this baby in emergency, right? So that is how we can treat these Hirschsprung disease. This is just a pictorial representation to show how the proximal colostomy is done. This is another pictorial impression which is showing a long aganglionic segment. As you can see here, there's a long aganglionic segment. Because of which the proximal colon has dilated, chances of perforation. If a long aganglionic segment is involved or aganglionic, then the story presents in a newborn baby, maybe at 4th day, 5th day or 7th day of life, and the chances of this proximal colon perforation are high. We have to do a transverse colostomy in these patients to avoid that perforation. So Hirschsprung disease, or a congenital megacolon or congenital aganglionosis. This is absence of ganglion cells in the nerve plexus, most commonly in the rectosigmoid. Rectum is always involved. Depending on whether the story is a short segment story or a long segment story. If it is a short segment which is aganglionic, if the short segment is not having the ganglion cells, then the story presents in childhood with constipation. To make the diagnosis, we do a suction rectal biopsy. This is the investigation of choice. Apart from this, we can do anorectal manometries. We can do anorectal manometry to study the pressures in the proximal colon. To know the extent of disease, we do a barium enema, and when we do barium enema, if you are seeing a narrow contracted part, this narrow contracted part is actually aganglionic. That means the pathological area. While the proximal dilated part is normal. The proximal dilated part is normal. To treat these short segment aganglionosis, we can do various operations: Duhamel, Swenson, Sovent-Park coloanal anastomosis. These are mentioned here: Duhamel, Swenson, Sovent-Park coloanal anastomosis. Another variation of this Hirschsprung disease, one was a OPD presentation, another is a emergency presentation. If a long segment is aganglionic, then the story presents in the neonate with intestinal obstruction. And if it is intestinal obstruction, then we do proximal colostomy. This is how we can relieve the emergency of the baby. If we can have a quick recap on Hirschsprung disease, this is congenital megacolon or congenital aganglionosis. There is absence of ganglion cells in the nerve plexus, most often affecting the rectosigmoid area where rectum is always involved. The entire presentation of Hirschsprung depends whether only a short segment is aganglionic or a long segment is aganglionic. If only a short segment is aganglionic, then the newborn baby will not be having any problems. But as the baby would be growing older in the childhood, when the aganglionic length also increase, then this child may suffer from constipation. We try to modify the diet and other things, but if nothing is helping and we start suspecting Hirschsprung, we can take a suction rectal biopsy and that will prove that ganglion cells are absent in a particular area. We can do pressure studies, anorectal manometries. We can do a barium enema to know the extent of aganglionic segment. When you're pushing the contrast through the anus, the pathological segment or the aganglionic segment will appear contracted, but the proximal normal segment will be dilated. You can do various operations like Duhamel, Swenson, Sovent-Park coloanal anastomosis. Sometimes, if suppose a large segment is aganglionic, long segment is aganglionic, then the story will present in the newborn baby itself, because the peristalsis which is coming in the colon may not be sufficient to force the fecal matter through such a long aganglionic segment, because of which there will be fecal impaction causing a complete traffic jam type of situation. The proximal colon will be distended grossly, baby presenting with huge distension of abdomen. To relieve the emergency of the baby, you can simply do a proximal colostomy. Right? Okay. Now moving ahead from this left iliac fossa area, if we go into the hypogastrium, herein we'll be talking about two problems. One is duplication of renal pelvis ureter and another is uretrocele. What actually these problems are? In a normal individual, beta, we all understand that you all who are watching this session, if we look on one side, there will be one kidney, there will be one renal pelvis, there will be one ureter. Right? Sometimes God may give you two renal pelvis and two ureters. This is called as duplication of renal pelvis and duplication of ureter. Now, if somebody is having two renal pelvis on one side, sometimes what actually happens, generally beta, the upper pelvis is small because it drains only the upper moiety, and the lower pelvis is actually large, which drains the middle and the lower moieties. But in this diagram, we are seeing a different story. Sometimes what happens, because of this narrow area, there might be a stenosis at the pelviureteric junction. The junction of renal pelvis and the ureter, this might be narrow, this might be stenosed, and this can create a traffic jam type of situation, because of which this proximal pelvis will enlarge. And sometimes this becomes so enlarged that it starts putting pressure on the lower pelvis, because of which the lower pelvis actually droops down. And when we take a IVP, we may find something like this. Can you appreciate it? This is actually a case of double renal pelvis, where we are not able to see the upper pelvis. Probably this has become non-functional. There was another pelvis in this area. There was stenosis at the pelviureteric junction, because of which the proximal pelvis got dilated, became non-functional, and now because of this dilated pelvis, it is putting pressure on the lower pelvis, and the lower pelvis is drooping down like this. This what you are seeing is called as the drooping lily sign. क्या बोलते हैं बच्चे इसको? What do we call this beta? This is a drooping lily sign. Drooping lily sign. Okay. A water lily sign is seen in hydrated cyst. Right. Another story beta. If suppose God has given 2 renal pelvis and 2 ureters, let us try to take a look in this IVP. Herein, if you carefully take a look, can you appreciate on this side there is 1 renal pelvis, another renal pelvis. This side there is 1 renal pelvis, another renal pelvis. So God has given 2 renal pelvis on both the sides, suppose. And suppose God has given 2 ureters also. Can you appreciate the double renal pelvis and double ureter on both the sides? Generally, in this duplication of renal pelvis and ureter, they follow a Mayer-Weigert law. According to that Mayer-Weigert law, if there are 2 ureters, then generally what happens? Generally, these 2 ureters, they join with each other so that there is only 1 ureter lower down, and if there is only 1 ureter lower down, then this would be opening normally in the urinary bladder. And then the story would be absolutely normal. But sometimes what happens, beta, if there are 2 ureters and these 2 ureters, suppose they do not join, then there will be 2 ureters lower down also. If there are 2 ureters lower down also, then 1 ureter will be opening normally, but the upper ureter usually passes distally and it opens more medially than its counterpart. It opens more medially than its counterpart. This is how the ureter is opening more medially. Since this ureter is not opening at the normal location, this ureter is called as ectopic ureter. In case of males, most often this ectopic ureter is found at the apex of trigone. Apex of trigone. However, we can find this ectopic ureter going even lower down, and it may open in the prostatic urethra, or this ectopic ureter may be opening in the seminal vesicles. In case of females also, it may become ectopic in location and may open somewhere else. If the ureter is ectopic, we can understand beta, अगर यूरेटर अपने नॉर्मल जगह पे नहीं खुल रहा है, कहीं भी और खुल रहा है, तो हो सकता है वो यूरिन किसी और जगह इकट्ठा होने लगे, जिसकी वजह से पेशेंट को तकलीफ होना शुरू हो सकती है. I repeat this in English. If the ureter is not opening at the normal location and is opening somewhere else, then urine may be coming somewhere else, and this may create some or the other complication in the patient. So we need to treat these ectopic ureters. IVP is the investigation of choice to see these ureters nicely. In the treatment, a simple treatment is, अगर कोई अपना घर छोड़ के कहीं और चला गया है, तो हमें उसका कान पकड़ना चाहिए और उसको कान पकड़ के वापस अपने घर में डाल देना चाहिए. Basically, if somebody has left his own home and has gone somewhere else, we should simply pakdo his kaan, bring him back and put it back at the normal location. So in the treatment of this ectopic ureter, we are simply doing ureteric reimplantation. Ureteric reimplantation, right? Let us see the story of this duplication of renal pelvis and ureter. Duplication of renal pelvis and ureter. This is the most common congenital anomaly of the upper urinary tract. If there are two renal pelvis, then we can find a drooping lily sign. In the various MCQ platforms, some MCQ books, the answer given for drooping lily sign is duplication of ureter. You can consider that answer if you do not have duplication of renal pelvis in the option. But actually the best answer is duplication of renal pelvis. Just to make a note that water lily sign is seen in hydrated cyst. Now what is this water lily sign in hydrated cyst? If I take you to the adult surgical problems, page number 147. Here is the water lily sign beta. You are able to see this is a hydrated cyst inside the liver where you can see the nice floating of the worm inside, just like the lily flower is floating in water. And that is why we call it as water lily sign, seen in hydrated cyst. Coming back, here we are just talking about the drooping lily sign, and I hope there is no confusion in this, that how here we are seeing that just like the lily flower, this is drooping down like this. This is drooping down like this because the upper pelvis is putting pressure on the lower pelvis. Right. In duplication of ureter, there's a Mayer-Wegert law. Usually what happens, if there are two ureters on one side, they join, and only one ureteric orifice is seen in the bladder on one side. Rarely what can happen, if there are two ureters on one side, and if they do not join, then the upper ureter passes distally and open more medially than its counterpart. That means this is not opening at the normal location, and we call it as ectopic ureter. In case of males, this ectopic ureter most commonly opens at the apex of trigone. It opens at the apex of trigone most commonly. However, it can open in the seminal vesicles or in the prostatic urethra. The patient presents with recurrent urinary tract infection, while in females, this opens distal to the distal sphincter. And this presents with dribbling urinary incontinence. Dribbling urinary incontinence. Dribbling urinary incontinence. Before we move forward, let us just try to revisit the anatomy of the urethra in males and females. Suppose beta, this is the urinary bladder. And here is the urethra. The length of male urethra is 16 to 20 centimeters. Female urethra is 4 centimeters. If we look at the male urethra, broadly there are two parts. This is the anterior urethra and this is the posterior urethra. I repeat beta. This what you're seeing, this is the anterior urethra, and this what you're seeing, this is the posterior urethra, right? the anterior and the posterior urethra. We know that here lie the prostate gland. So that part of posterior urethra which lie within the prostate is called as prostatic urethra, and that part of posterior urethra which lie below the prostate, that is called as membranous urethra. That means this is the prostatic urethra, and below this will be the membranous urethra. Right? Now, if we take a look at the anterior urethra, again we can divide this into two parts broadly. That part of urethra which is lying in the perineum is the perineal or bulbar, and that part of urethra which lie within the penis, this is penile urethra. Right, beta? This is just a broad outline. Another thing which I would like to share here, in case of males, beta, there are two sphincters. One is the internal sphincter and another is the external sphincter. Internal sphincter is located at the bladder neck. External sphincter is located in the membranous urethra. So you can make a note of this. This is the internal sphincter. And here, this is the external sphincter. Just a brief outline about the male urethral anatomy. When we are saying ectopic ureter, now ectopic ureter, normally what is happening, beta? Normally, if suppose we just try to use this image, on this particular side there were two ureters but they joined with each other, so that there was only one ureter which was coming down and it was opening normally in the bladder. That means on this side there will be only one ureteric orifice and that will be normal in the bladder. But on this side, if there are two ureters and they do not join, then one ureter opens normally, the other ureter becomes ectopic. That means one ureter will be opening normally, but the other ureter will become ectopic. And then this ectopic ureter may be opening at the apex of trigone, or this ureter may be opening in the prostatic urethra, or this ureter may be opening in the seminal vesicles. Right? This is what is ectopic ureter. Suppose this ectopic ureter is opening in the seminal vesicle or in the prostatic urethra, the urine will collect in these areas and stasis of urine will lead to infections, recurrent UTIs. Recurrent urinary tract infections can occur because of this ectopic ureter in case of males. Right. Now in females, beta, if we take a look, there is only one sphincter in females and that is called as the distal sphincter. There is only one sphincter in females and that is called as the distal sphincter. And if by chance, suppose I say, the same rule we are trying to use in a female, on this side there may be a normal ureter, on this side the lower ureter may be opening here, but the ectopic ureter is opening distal to the distal sphincter. That means this is the ureter which is coming, the ectopic ureter. That means whatever urine would be coming from this ectopic ureter, whatever urine is coming here, that urine will be coming here. And you can nicely see, beta, there is no sphincter beyond this. That means whatever urine is coming here, there is no control. जो आ रहा है, वो जा रहा है. So this girl will be presenting with continuous dribbling of urine. Whatever ureter is opening here, urine is coming here, bladder is filling, sphincter is normal. She will be passing this urine normally as a normal person. But apart from this, if there is ectopic ureter which is opening here, urine will be continuously coming here and she will be continuously passing the urine. This is a dribbling urinary incontinence. That is how ectopic ureters can present in females. On 17th of December, they might cook a story for you ki beta, there is a 2-year-old girl child who is having normal bladder filling sensations. She is able to pass urine normally, but at the same time, she is also complaining of continuous dribbling of urine. What can be the likely pathology? The answer will be ectopic ureter. Right? Okay. Fine. Investigation of choice for these double ureters, we can do IVP or IVU. That is one and the same thing. Nowadays we use the term IVU more often. And the treatment for these ectopic ureters we understand nicely. जो अपना घर छोड़ के चला गया है उसका कान पकड़ा जाए और वापस उसको अपने घर में डाल दिया जाए. In these ectopic ureters, the treatment is simply you just take this ureter and put it back into the bladder. That is ureteric reimplantation. Ureteric reimplantation. Another pathology which is related to these ureters is ureterocele. And this is a famous pathology because of an image-based question. This is the image-based question which is commonly asked in your exams. Can you see some laddus here? These laddus, what you're seeing here, this is looking like a cobra head or a adder head appearance, just like a cobra. Now, what actually is this? If we just try to understand, suppose this is the ureter. This is the ureter, and on this side, suppose the ureteric opening is normal. Great. On this side, if suppose I say that there is partial atresia of the ureteric opening, partial atresia means suppose the ureteric opening is like this. That means there is some traffic jam type of situation. What will happen? When the urine is coming from this, because of a traffic jam situation, the proximal people are going to get dilated. So what will happen? this proximal ureter is going to get dilated. And because of this dilatation, if suppose you are doing a contrast study in this, what you can find, the contrast would be coming here nicely. And then the contrast will be getting holded up into this area. And now what can happen, beta? If suppose the proximal muscles contract forcefully, they will force the contrast to pass out. And this appearance, what we are seeing right now, this looks like a cobra appearance or a adder head. And when the contrast tries to pass out from this, it appears as the snake is taking its tongue out. ऐसा लगता है जो कोबरा है ये अपनी जीभ बाहर निकाल रहा है. This is what we can see. Right. So that is what we call as the adder head appearance. Something like this. When the contrast comes out, it appears as if the snake is trying to take the tongue out. That is why we call it as cobra head or adder head appearance, right? This uretrocele, please remember beta, ये जो है ये uretrocele है. Do not confuse with urethrocoele. Your examiners, you know what they did once? They mentioned the options as uretrocele, urethrocoele. And A option was urethrocoele and C option was uretrocele. As soon as you saw urethrocoele, you thought that yes, this is what is the answer, uretrocele. And many students marked the urethrocoele as the answer. That was actually a silly mistake, right? So please be careful. This is not urethra. This is ureter. So what happens here is, this is partial atresia of the ureteric orifice. Usually the story is bilateral, common in females in childhood. Because of stasis of urine here, we know the concept, the funda of stasis. Whenever there will be a traffic jam, proximal dilatation, stasis, infection in the urinary tract infection. What we can do is IVU, or you can say IVP, and herein we find the cobra head or adder head appearance. Adder head appearance. कोबरा हेड और एडर हेड अपीयरेंस. ध्यान से देख लीजिए बेटा इस फोटो को भी अपने सीने में बसा लीजिए. दिस इज अ हॉट इमेज बेस्ड एमसीक्यू. That laddu is what you are seeing here. And you may find that when the contrast is coming out, something like this, right? So that is what you can see. A simple treatment, what we can do in these pathologies, beta. Cobra just above my head. Right. What we can do here, beta, a very simple treatment. We want to get rid of these dilatations. So, beta, you can pass a endoscope, and here you are seeing this endoscope. This is passed through the urethra into the bladder. So this is a cystoscope. Through the side channel of this endoscope, you can pass some instrument. I'll have to change the color, I guess. So when you're passing this instrument, this is a knife, you cut the ureteric orifice. As soon as you cut the ureteric orifice, this orifice will relax, the pressure here will be released, and all this story will become normal. So you have to just make a longitudinal cut on the ureteric orifice, right? This is what we call as endoscopic longitudinal incision of the ureteric orifice. Whenever we are damaging the ureteric orifice, beta, there is always a risk that whatever saman is inside the bladder, whatever is there inside the bladder, that can reflux into the ureter. So you know what is there inside the bladder. Inside the bladder there is urine. If you have done this operation and you have damaged the ureteric opening here, then what can happen? There may be reflux of urine into the bladder. So this urine will be going into the there will be reflux of urine from the bladder into the ureter, and this reflux is what we call as vesico-ureteric reflux. Once again, vesico-ureteric reflux. If we have to demonstrate this reflux from bladder into the ureter, what we can do is we can pass a catheter into the bladder, push the contrast inside the bladder, and now you remove the catheter. The catheter is out, there is contrast in the bladder. Take this baby in the X-ray room, ask this baby to pass urine on the X-ray table. As soon as she starts passing urine on the X-ray table and the bladder starts contracting, then this contrast from the bladder, if there is reflux, will start going into the ureter, and you will be seeing the reflux of contrast into the ureter, right? So that is how on micturition we can demonstrate this vesico-ureteric reflux, right? Okay. Vesico-ureteric reflux can be the complication of the surgery, and beta, you know the investigation of choice for vesico-ureteric reflux is MCU, micturating cystourethrogram, or avoiding cystogram. Another pathology where MCU is the investigation of choice is posterior urethral valve. Now, what are these posterior urethral valves? If we take a look at an image, right. Now, suppose, beta, this is the urinary bladder, this is the urethra, this pinky thing what you're seeing is the prostate. So this part of urethra will be the prostatic urethra, and here will be the membranous urethra. This prostatic urethra is normally having a fold of urothelium inside. There is a fold of urothelium in the prostatic urethra, which is called as verumontanum. वीरू बोलते बेटा इसको, हाँ, सारे बॉयज में, all the boys, there is a normal verumontanum present. This is just an elevation in the floor of prostatic urethra. This is made of urothelium only, right? All the boys have this. Sometimes what can happen, only in boys, we may find valves in this prostatic urethra distal to the verumontanum. And if these valves are present here, the direction of these valves is such that they can allow anything to pass from below upwards, but they will not allow something to pass from above downwards. And normally, beta, we know that the direction of flow is from above downwards, right? So that can be a issue. Now, it depends whether these valves are complete or incomplete. For example, if suppose I say that this is the prostatic urethra here. I know that in the prostatic urethra, there is a normal fold of urothelium which is called as verumontanum. Sometimes we can find valves in the prostatic urethra distal to the verumontanum. Okay? There can be two things, beta. Like this picture, what you're seeing, the valves are not complete. They are incomplete. Sometimes the valves are complete. This is a complete valve. Just like Hirschsprung disease, beta, if only a short segment was involved, the story presented in childhood. If a long segment was aganglionic, then the story presented in a newborn baby. The same concept, beta, you apply here. If suppose the valves are complete, there's a complete traffic jam. As soon as the baby is born, when the baby has to pass urine, there's urine all over here. Now, when the baby is trying to pass urine, the urine is coming here, but the urine is not going out. So the urine is getting holded here, and the pressure in this proximal part is increasing. Pressure in the proximal part is increasing. So what will happen? All this area will get dilated. All this area will get dilated like this. And this is an emergency situation. How to relieve this emergency, beta? The chotu sa baby, the neonate, he might be having distension in the lower abdomen. The bladder might be grossly distended, and when we come to know, we ask the nurse, we ask the mother, has the baby passed urine? No, we have not seen, the baby has not passed urine at all. And the baby is in discomfort. So what you can do is you can quickly put a fine catheter. You can just put a fine catheter, beta, and you know, even if there is posterior urethral valve, you can pass anything from below upwards, so that when the catheter is being passed, then these valves are going to open up and they will allow the passage of catheter. As soon as the catheter goes up into the bladder, the urine will start coming out and the baby will be relieved. Just a simple urethral catheterization will relieve the emergency of this baby. What we were doing in Hirschsprung disease, beta, there was a colonic obstruction, we were doing a colostomy. Here, the baby's retention of urine, we are simply putting a urethral catheter and relieving the retention. If by chance you are not able to pass this catheter, if suppose you are trying to pass this catheter, but suppose you are facing some resistance and you are not able to pass the catheter, do not force. No means no. Do not force. No means no. Right? So in these cases, it is better that you remove this and you can pass a catheter from above. You can pass a catheter from above, right? This is called as suprapubic cystostomy. So to relieve the retention in the baby, you can simply put either a catheter from the urethra, or if you're not able to pass a urethral catheter, you can put a suprapubic cystostomy. That is how we can deal with the emergency situation. Another situation, beta, wherein suppose we say that these valves are not complete, these valves are incomplete, something like this. That means there is sufficient rasta for the urine, there is sufficient passage for the urine, and the baby would be passing urine normally. So the story may not be presenting in the newborn baby, but as the baby is growing older and older, in childhood, there is a possibility that when the urine comes here, there is some resistance And because of this resistance, sometimes some amount of urine may remain holded above. Stasis can lead to infections. The chances of recurrent urinary tract infections would be high. So this is how the story can present. If the valves are complete, story presents in the newborn baby with retention of urine. If the valves are incomplete, the story will present in childhood with recurrent urinary tract infections, right? To diagnose these valves, if suppose I say that you are doing the retrograde urethrogram, suppose these are the valves here. Wait. Suppose these are the valves here. Here there was Viru montanum. Now, if suppose you do a retrograde urethrogram, which is the study of choice for urethral studies. In a retrograde urethrogram, beta, what we are doing generally, we are simply putting the catheter just inside the urethral opening for maybe 1 centimeter or 2 centimeter. And then we push the contrast. When you are pushing the contrast, beta, the contrast is traveling somewhat like this. See, you are pushing the contrast. Can you appreciate that you are pushing the contrast? The contrast is going up, the contrast is going up, the contrast is going up. And now what will happen? These valves will allow passage anything from below upwards. So the valves will open up. And then the contrast will be going up into the bladder. And you will not be able to see any traffic jam. That means retrograde urethrogram is not the study to diagnose these posterior urethral valves. What we need to do is, we need to, what we want here is, we want that contrast should flow from above downwards. Now, what you can do in this, you can simply pass a feeding tube into the urinary bladder, and then through this you can push the contrast inside the urinary bladder. The contrast is inside the bladder. Now you can just take the feeding tube or the catheter out. As soon as you take this catheter out, the catheter is out. Now you take this boy in the X-ray room and ask this boy to pass urine. As soon as the boy starts passing urine, now what you can notice here, the urine is coming here, coming here, coming here, coming here. But now the valves are going to close. So there will be some resistance here. And because of the resistance, there might be holding up of the contrast in this area only. And you might be seeing a traffic jam situation at this level, right? That is why we say micturating cystourethrogram can demonstrate these posterior urethral valves. If we take a look at some of the images, beta, these are the images what you can see in posterior urethral valves. Just try to appreciate this. We have put the contrast in the bladder and we are allowing the contrast to come down. There is holding up of the contrast here, and you are seeing a traffic jam type of situation in this area. Right? Another picture, beta. Now here, this what you are seeing, this is the posterior urethra. This what you are seeing is the bladder. So the contrast was there inside the bladder, and now the patient is micturating. When the patient is micturating, the contrast is coming down, 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 up to this level. And now the contrast is not seen going down nicely, right? So this would be the site of obstruction. That is how MCU can show us about these posterior urethral valves. In the treatment for these posterior urethral valves, in the elective scenarios, beta, what we can do is we can simply pass a endoscope you can simply pass a endoscope. Take the endoscope here. Through the side channel of the endoscope, you can pass some instrument inside, and with the help of this instrument, you can just try. Suppose this is the instrument which you are passing. This would be a knife, and now you can simply resect these valves. This is called as transurethral resection of the valves, or you can destroy these valves by heat, transurethral fulguration of valves. Right, so that is how we can treat these posterior urethral valves. Right. Let's see what all is written in the workbook. I hope, beta, you got the concept of this posterior urethral valve nicely. Most commonly, these posterior urethral valves are present in the prostatic urethra. Distal to viru. Distal to viru. Viru montanum. Viru montanum. These are seen only in boys, not in girls. The stories, beta. Incomplete valves, complete valves. Incomplete valve presents in OPD, childhood, recurrent urinary tract infection, investigation of choice micturating cystourethrogram, treatment transurethral resection of valves, or we can do transurethral fulguration of valves. Fulguration of valves. Transurethral resection or transurethral fulguration of valves can be done. If the valves are complete, the baby will present an emergency. Newborn baby, uski nikal nahi pa rahi hai, he is having retention of urine. What we can do, we can simply put a catheter from the urethra, immediate urethral catheterization. If we are not able to pass it, you will do a suprapubic cystostomy. Suprapubic cystostomy. Right? Fine. Another pathology is hypospadias. Now, hypospadias suppose I'm just trying to draw the penile shaft. In the penis, there are two corpora cavernosas and one corpora spongiosa. The brown colored what you're seeing are the corpora cavernosa, and the pinky what you're seeing is the corpora spongiosa. This is the glans. Glans is made of corpora spongiosa only. There is no cavernosa in the glans. That is the reason why glans is a spongy tissue. And we know that the urethra is passing through this corpora spongiosa, and normally the urethra is present at the terminal point of glans, like this. right? The urethral opening, this is situated here. This is the normal story. Now, if suppose we say that this is something which is normal, if the urethral opening is not present here, but is present anywhere on the under surface of penis, then we call it as hypo. If this urethral opening is not present here, but is present anywhere on the upward surface of penis, then we call it as epispadias. So epispadias and hypospadias, right? Epispadias is very rare. Hypospadias is very common. This is the commonest congenital abnormality of male urethra. Now, if you take a look, and let us just imagine that this is the ventral surface of penis. Ideally, the external opening should be present at the tip of the glans here. But if the external opening is not present at the tip here, rather it is present anywhere on the under surface of penis, that is what is hypospadias. And based on where the ectopic opening is present, we can classify these hypospadias into, if it is present at the glans, it is granular, at the coronal sulcus coronal, just beneath the coronal sulcus subcoronal, and then comes the penile shaft, distal penile, mid penile, proximal penile. If it is located at the junction of penis and the scrotum, then penoscrotal. If in the scrotum, then scrotal. If in the perineum, then perineal type of hypospadias. So depending on where the external urethral opening is present, we can classify these hypospadias accordingly. For example, beta, once again I'll repeat this. Suppose I use a dark blue color to demonstrate. If the opening is present in the glans, beta, then it is granular. If the opening is present at the coronal sulcus, that is coronal. This is subcoronal. This may be distal penile, mid penile, proximal penile, and now here suppose is the junction of the penis and the scrotum. Suppose the scrotum would be lying somewhat like this. If the external opening is present here at the junction, this will be peno. Let me just remove myself. How can I come in front? This is penoscrotal. This will be scrotum, scrotal, and here this will be perineum. So that is how we can classify these different types of hypospadias. This is the most common congenital anomaly of male urethra. The incidence is 1 in 200 to 300 male live births. Suppose whatever city you are living in, if there are 200 male babies born today in that city, 1 out of those 200 male baby would be having this hypospadias problem. So February 23, when you will be working in the hospital, you will be coming across these hypospadiac babies quite often. Now, which type of hypospadias is more common? Which type is less severe? Which type is more severe? So beta, one thing which is very clear in our minds, that opening which is more near the normal, opening which is more close to the normal, that means this will be more common, and opening which is away from the normal, that would be less common. So examiner may give you any type of hypospadias in the option. You have to just see if he's asking more common, then out of the given option which is more close to the normal, that will be more common. If he asks you less common, then opening which is far from the normal, that will be less common, right? Then he may ask you which is less severe. Opening which is more close to the normal will be less severe. Opening which is more far from the normal will be more severe. Like, out of the given options, glandular will be the most common. No treatment is required for glandular. It is the least severe type of hypospadias. There can be coronal, subcoronal, distal penile, mid-penile, proximal penile, penoscrotal, scrotal, and the perineal type of hypospadias. Perineal type will be the most severe and the least common type of hypospadias. It has been observed that if the mother has been taking estrogen, diethylstilbestrol during pregnancy, this can be associated with hypospadias in the baby. And if it is a perineal type of hypospadias, we are not able to difficult the sex in these babies. Sex is difficult to differentiate in perineal hypospadias. Let us try to take the actual picture. Let us try to understand what is going to be the problem. Actually speaking, beta, if suppose normally the story is somewhat like this. But now the story is somewhat like this. That means the urethra in this patient, which was earlier going like this, now it is not going like this. Now it is actually going like this. That means there is no urethra. There is no urethra in this area. Plus the spongious around the urethra will also not be there. Absence of urethra in this area will form a fibrous cord type of thing. Instead of urethra, there will be a fibrous cord type of thing in this area. And because of this fibrous cord in this area, this is going to cause bending of the penis. That is chordae. Chordae is simply down curvature of the penis. Chordae is simply curvature of the penis. Urethra is present only up to this area, beta. No urethra here. Rather, there will be a fibrous cord present here instead of urethra. And this fibrous is hard. So this is going to put pressure. So the penis is going to bend down like this. That means the penis, instead of like this, it will actually become somewhat like this. Something like this. What will be the problem in this baby if we try to take a look? See, this is another picture to demonstrate the different types of hypospadias. This is how the different types of hypospadias can be seen. This is the curvature of the penis, what you can see. Now, normally, beta, let me remove myself, otherwise, normally, beta, the baby is passing urine like this, so that the urine of the baby is actually falling in front like this. But in a hypospadiac baby, what is happening? The penis is actually getting downward curvature, so the penis is actually buried within the scrotum. So whatever urine is coming, that is falling onto the scrotum and onto the thighs of the baby. Also, beta, in future life, when this boy will grow old, because of that fibrous cord, because of the downward curvature, this boy will not be able to achieve adequate erection. then how will he be able to deposit the sperms in the vagina? These are serious issues, and we need to do something. We want that this boy should be able to pass urine like this. How to achieve this? We can do a surgical correction. For example, first thing what we have to do is we want to make the penis straight. So whatever fibrous cord was present here, we have to take that fibrous cord out. So we do a surgery and we remove that fibrous cord. Right? And then the penis can become straight. So after removing the fibrous cord, we make the penis straight, somewhat like this. And now what we want to achieve is the urethral opening which is present here. We don't want the urethral opening here, but we want the urethral opening here. That means we have to do something. We want the urethral opening here and not here. You have corrected the curvature. The urethra is actually coming up to this point. But you want the urethra right up to this point, right? So how to get this urethra? Can we go to the chemist shop and ask the chemist, Bhaiya, ek dena zara? Chemist shop. Will the chemist be having this urethra? No. That means we have to do something and reconstruct this urethra from something inside. Now, what we can do is, we can take the help of this prepuce. Prepuce is the foreskin, what you are seeing here. This is the foreskin. We can do surgery and we can remove this prepuce from here. We can take a flap from the prepuce, make a tube from this prepuce and rotate this tube and then connect the old urethra with that preputial tubular flap. So you can make a connection here. This is the preputial tube which you have made. And that is how a new urethra can be made. You can take prepuce, you can even take the fascia of the scrotum to make this urethra. There was one very renowned surgeon in India, Dr. Hari Shankar Asopa. He had been a pioneer in hypospadias surgeries. He hails from Agra. His chapters of hypospadias surgery are there in Urology Campbell textbook. He showed that there are people who even used buccal mucosa to make the urethra. Buccal mucosa for making the urethra. It was not that they created a tunnel from the mouth up to the penis, so that, and then he simply harvested the buccal mucosa, made a tube of it, and made this urethra. So there have been so many things which have been used to reconstruct this urethra, but commonly we are using the prepuce. Now, if we are using prepuce for making the new urethra, then circumcision should not be done. In Jews and Muslims, we know for religious customary reasons, circumcision is something which is a routine. But if even a Jew or a Muslim baby is having hypospadias, then circumcision is contraindicated because we are going to use that prepuce to make the new urethra. Sometimes when we are doing this surgery, what can happen? We are putting the sutures here to connect the old urethra and the new urethra. You would have put some sutures here to connect the old urethra with the new urethra, and you know that urine is continuously coming here. even after surgery, the urine is coming here. The urine can make these sutures wet, and these sutures can break sometimes. If the sutures break, then urine will start leaking here. And many a times we have seen that urine gets collected in this area, and then because of the pressure of urine, a hole develops in the skin and urine starts coming out from here. That is, a abnormal connection develop between the skin and the urethra, that is called as fistula. So a common complication of this hypospadias surgery is a urethro-cutaneous fistula, from where the urine can leak outside, right? Okay, now let's see what all is written. This hypospadias is associated with CORDY, that is downward curvature of the penis. There may be meatal stenosis. The problems encountered are in urination, erection, and sperm deposition. The treatment for this hypospadias is surgical correction. Basically, we need to correct the CORDY correction, and then do a urethral reconstruction, that is urethroplasty. Urethroplasty. Ideal age of operation is 10 months. However, this operation can be done between 6 to 18 months of age. Most commonly, we are using prepuce for urethroplasty. Circumcision is absolutely contraindicated in hypospadias, and a common complication of surgery is a urethro-cutaneous fistula. A common complication of surgery here is a urethro-cutaneous fistula. Right, beta. So we are done with the majority of the things except one topic here. If we take a look at the indexing of pediatric surgery once again, we have discussed the cleft lip palate, the neck swellings, the esophageal atresia, the epigastric stories, right hypochondrial stories, lumbar stories. Then we talked about right iliac fossa, the Meckel's diverticulum, left iliac fossa, the Hirschsprung disease, the hypogastrium, duplication of ureter and ureterocele. We talked about posterior urethral valves and hypospadias, and now we are left with undescended testis or cryptorchidism. So what we'll do here is we'll take a break here, and we'll be back after the break. Then we'll be revising the entire pediatric surgery, and we'll be doing the workbook questions, right? So we will be back at 4:50 p.m. Thank you very much for your patience. Right, beta. So let's talk about in something related to scrotum. Now, this is a hot topic, which we know that they have been continuously asking something related to this in the last 5 exams. Undescended testis or cryptorchidism. What is this story basically? If we try to take a look, here lies the scrotum, and here is the inguinal canal. Now, generally what happens, Peter, during intrauterine life, the testes are actually developing in the retroperitoneum. And these testes, they actually follow a defined path. For example, during intrauterine life, they, from the retroperitoneum, gradually, they come at the deep inguinal ring. And from there, they start descending into the inguinal canal, and then just before birth, they drop down to the bottom of the scrotum. This is the normal story. If they are able to reach to the bottom of the scrotum, that means the story is normal. But if they are arrested anywhere in this normal path of descent, then we call them as undescended testes. If they are reaching to the bottom of the scrotum normally, they are normal. But even if they are arrested at this point, that is even at the top of the scrotum, then we call them as undescended. Or they may be found anywhere in this inguinal canal region. Now, if they're found anywhere here also, then also we call them as undescended testes. So one thing which is very clear, that this is the normal path of descent of testes. Sometimes what can happen, during their descent, they might change their path and they may come to lie somewhere else. For example, if they deviate from the normal path of descent and come to lie somewhere else, maybe here, maybe here, maybe here, anywhere. If they deviate from the normal path of descent and come to lie somewhere else, they are called as ectopic testes. So there are two terms, Peter. One is undescended testes. Undescended testes, I repeat, if by chance the testes are arrested anywhere in the normal path of descent, whether it is the top of the scrotum or maybe at the almost at the superficial inguinal ring, or maybe in the inguinal canal, or maybe at the deep inguinal ring, all this will be called as undescended testes. But if they deviate from the normal path of descent and come to lie somewhere else, they are called as ectopic testes. In Hindi, जब टेस्टिस अपने रास्ते में कहीं पे अटक जाती है तो अनडिसेंडेड, अगर भटक जाती है तो एक्टोपिक. Right? I hope This is going to help you in remembering what is undescended and what is ectopic. Now, if we take a look at this boy, which sided testis is undescended in this video? This is right, this is left. You can see fullness in the right scrotum, but the left scrotum is empty. So probably the testes are not present here. They may be undescended or ectopic or whatever, right? This undescended testis is also called as cryptorchidism. This is the commonest congenital anomaly of male genitalia. The incidence is almost 3% in a full-term baby. That means if in your city today 100 male babies are born, then 3 out of these 100 male babies would be having this undescended testis. But the best part is 75% of these undescended testes can descend down to the bottom of the scrotum within the first 3 months of life, sometimes even 3 to 5 months of life. That means if today suppose there were 3 male babies out of 100 in one hospital who had undescended testes at birth, out of these 3 babies, 75% of the times the testes are going to descend down to the bottom of the scrotum. That means out of 3, 2.25 babies, or we can just assume that suppose there are 4 babies who are having this undescended testis, then 3 babies, the testis will descend down to the bottom of the scrotum spontaneously within 3 months of life or maybe 5 months of life. So we as doctors will not be requiring to do anything in these cases because God is spontaneously descending the testis down. We will be required to intervene in those babies where the testes are not able to descend down to the bottom of the scrotum. The commonest site of undescended testis is the inguinal canal. Ectopic testis can be found at various places. Maybe they may be found at the femoral ring, perineum, root of the penis. For example, here would be the femoral ring. Root of the penis is here. Perineum is behind the scrotum somewhere here. The commonest site of ectopic testis is actually the superficial inguinal pouch. So, these can be the undescended and ectopic testis story. Now, what can be the problem in these undescended testis? There can be complications which are remembered by the mnemonic A testis, A for atrophy, T for trauma, E for epididymoorchitis, S for sterility, T for torsion, I for inguinal hernia, and S for seminoma. These can be the complications which we can see in undescended testis. Most common complication being the inguinal hernia. Sterility can occur if both the testes are undescended. If only one testis is undescended, then sterility won't be there. Why sterility can be a complication of undescended testis? Because we know in males, God has thrown the testis out of the abdomen into the scrotum because the intra-abdominal temperature is higher by 2 degrees centigrade as compared to scrotum. And if the testis remains intra-abdominal, then because of higher temperature, spermatogenesis will not be proper, and that will make the patient sterile if both the testes are intra-abdominal. And apart from this, there is one term which we call as retractile testis. Now, retractile testis is a condition, beta, where there is no problem at all. The testes are actually normally descended into the scrotum. Just look at the screen. Retractile testis is a condition where the testes are normally descended in the scrotum. But sometimes what can happen? If you try to scratch the skin of the medial aspect of thigh, suppose I try to scratch the skin on the medial aspect of thigh, there is contraction of the cremasteric muscle, and because of the cremasteric muscle contraction, the testis gets pulled up. Sometimes we see this when the baby is crying excessively. For example, February 23, you are sitting in your OPD with that white coat and stethoscope, and a mother comes with a 10-month-old baby. As soon as the baby looks at you, the baby feels insecure and the baby may start crying. Because of this excessive cry also, we have seen that sometimes the testis gets pulled up into the inguinal canal. Now, when you are examining these babies, you find that the scrotum is empty and you start thinking whether it's a case of undescended testis. If you carefully examine the inguinal canal, it is possible for you to bring the testis down from the inguinal canal to the bottom of the scrotum. If you are able to bring the testis down to the bottom of the scrotum, then it is not undescended or ectopic. It is just a retractile testis which ascended upwards either due to cremasteric contraction or sometimes due to excessive jerk. No treatment will be required for retractile testis. However, if we talk about these undescended testis, if this is the presentation and suppose you are not able to bring the testis down, basically in these cases you have to do the clinical examination, you have to feel the inguinal region nicely. If you are able to feel the testis in the inguinal canal, which you are majority of the times, then you may not require any investigation, but you can do the ultrasound for confirmation. Sometimes you may not be able to feel the testis here. You do the ultrasound and ultrasound also is not able to tell you about the location of testis. You can do a diagnostic laparoscopy, put a laparoscope inside the abdomen, look towards the inguinal canal region. You may be seeing the testis hanging just beneath the deep inguinal ring in the peritoneum. Once the diagnosis is made, the treatment is very simple. We do not interfere up to 3 to 5 months or 3 to 6 months of age. But if the story has not settled even at 6 months, then we can do a small operation. We can just make a cut on the inguinal canal here. If the testes are located in the inguinal canal, we mobilize those testes. We make a small cut here as well. We pass an instrument from here. Take this instrument here from inside. We tie a thread in the testis. We hold the thread with this instrument and then we try to pull the instrument. So the thread is tied to the testis and the thread is holded by the instrument. When you're pulling the instrument, the testis is also getting pulled from inside and the testis can be brought down to the bottom of the scrotum, and then you have to fix the testis in the bottom of the scrotum. Fixing of something in surgery is called as pexy. Fixing is called as pexy. Fixing the testis is called as orchidopexy or orchipexy. Orchidopexy. Right? Okay, beta. Now let's see what all is written here. Undescended testis or cryptorchidism. This is the most common congenital anomaly of male genitalia. The incidence is 3% in a full-term baby at birth. If the baby is born before term, then obviously the chances of undescended testis will be high. Generally, right-sided are slightly more common. 50% of undescended testis are right-sided, left-sided 30% and bilateral 20%. 75% of these undescended testes descend into the scrotum within 3 to 6 months of life. Undescended testis means when the testis is arrested in the normal path of descent. When the testis is arrested in the normal path of descent. And ectopic testis is when the testis deviate from the normal path of descent. अगर टेस्टिस अपने रास्ते में कहीं पे अटक जाती है तो अनडिसेंडेड, भटक जाती है तो एक्टोपिक. A retractile testis, when the testis ascend upwards but can be brought down to the bottom of scrotum. But can be brought down to the bottom of scrotum, that is retractile. No treatment is required for retractile testis. Most common site of undescended testis, it is inguinal canal. Undescended testes are most commonly seen in the inguinal canal. Most common site of ectopic testis is the superficial inguinal pouch. Superficial inguinal pouch. This is also called as the Dennis-Brown pouch. This was a question on 4th of June. What is the commonest site of ectopic testis? And in one of the options they mentioned superficial inguinal pouch. However, the ectopic testis may be found in the femoral ring, perineum, or root of penis. Complications which can occur in undescended testis are remembered by the mnemonic A testis: atrophy, trauma, epididymoarchitis, sterility, torsion, inguinal hernia, and S here is for seminoma. Most common cancer developing in undescended testis is seminoma. Most common cause of seminomas or most common cause of testicular cancer is undescended testis. When we do the clinical examination, inspection, palpation, we are able to feel these testes. We can do ultrasound of the abdomen and scrotum, and if needed, we can do a diagnostic laparoscopy. The treatment is orchidopexy, and the ideal age of operation is 6 months. However, generally we are doing this between 6 to 12 months of age. There has been a huge controversy regarding the age of orchidopexy, because when you'll be solving the questions on different platforms, you might be finding different answers for this age of orchidopexy. I would just like to brief you beta that when I was doing my MBBS, that was in the final year I was in, that was 1997, when I was doing my final year MBBS. Then at that point of time, the books used to write that orchidopexy should be done before puberty, because it is at puberty that spermatogenesis is going to take place. And if we don't bring the testes down, then because of high intra-abdominal temperature, the patient might face problems. Gradually, we realized that the changes for spermatogenesis actually start developing very much earlier. And gradually, then the books and the studies used to suggest that orchidopexy should be done in a preschool baby. That means 3 to 6 years. Then the study showed, no, it should be done even earlier. Then the age of orchidopexy came down to 2 years. And for a long time, the age of orchidopexy was considered as 2 years. Gradually, it started reducing, then 1 year. And now within 1 year, or maybe 6 months, the way this age of orchidopexy was reducing, we started thinking that probably a day may come when the books may start writing that we should do orchidopexy in the intrauterine life only. When the male fetus is inside the mother's uterus, then we should open the mother's abdomen, open the mother's uterus, then go into the baby, into the fetus, and open the fetus inguinal canal and bring the testis down into the scrotum. God knows what is future. But as of now, for 17th of December, we know that orchidopexy should be done at 6 months of age, preferably 6 to 12 months. These are just some miscellaneous points which have been written here because undescended testis is something which is associated with testicular cancer. There is very high risk of testicular cancer with undescended testis. Testicular cancer is the commonest cancer in a young male. Elderly male, prostate cancer. Female, breast cancer. Right? So there are some small important points. Let us write them here. Most common malignancy in a young male. This is not having any relation with the topic beta. This topic of pediatric surgery has ended here. Most common malignancy in a young male is testicular cancer. Elderly male, prostate cancer. Female, breast cancer. Rural India female, cervical cancer. Most common cause of testicular cancer, undescended testis. Undescended testis. Most common malignancy in undescended testis, seminoma. These are germ cell tumors, the testicular tumors, maybe seminomatous, non-seminomatous. Most common are seminomas. So most common testicular malignancy is also seminoma. However, most common testicular malignancy in elderly male, it is lymphoma. Elderly male testicular cancer is lymphoma. Second most common malignancy of the testis is non-seminomatous teratomas. Right, beta. So these are some important points related to this testicular malignancy and miscellaneous. So this is all about our pediatric surgery. Now, what we are going to do here is we'll be revising the entire pediatric surgery. And what I feel is, let us first do the revision with the workbook, and then we'll do the revision without the workbook, right? So that if we are able to complete this, that means we would be almost done with 60% of surgery, because now whatever is left, that is something which is already related, you have actually got the crux of those topics. Right, beta. So I hope we did not miss out on anything. Just a quick recap. Let us have that pump inside. So we talked about the cleft lip palate, the different neck swellings, the esophageal atresia, in the abdomen, the stomach duodenum stories, the biliary channel stories here, intussusception also, the kidney problems, Meckel's, Hirschsprung, the ureteric problems here, the urethra problems here, and the scrotal problems here. Right. Now, in cleft lip and palate, this is the commonest congenital anomaly of orofacial structures. Combined cleft lip and cleft palate is the most common, followed by cleft palate, then cleft lip. Combined cleft lip and palate 45, cleft palate alone 40, cleft lip alone 15. Cleft lip are more common on the left side. Reason: genetic and environmental factors. Environmental factors can be maternal epilepsy, or if the mother is taking some drugs during pregnancy like phenytoin, diazepam, or steroids. One syndrome, Pierre-Robin syndrome, that is isolated cleft palate. Retrognathia, that means the jaw has gone inside, and posteriorly displaced tongue, that is glossoptosis. These were the images which were relevant for us. The unilateral partial cleft lip, left side. This is a bilateral partial cleft lip. This is a unilateral right-sided complete cleft lip. This is a bilateral cleft lip, complete. And this, what you're seeing, is the cleft palate. Okay. Now, The problems what we know these babies might face, they will be related to their airway, swallowing, speech, dentition. Cleft lip can be diagnosed on antenatal ultrasound after 18 weeks of pregnancy. The treatment for these cleft lips and palate would be surgical reconstruction, plastic surgery. Like for cleft lip, we do Millard's and Wardell's operation, usually around 3 months of age, maybe 3 to 5 months, soft palate 6 months, hard palate 12 to 15 months. Then we move down into the neck. In the neck, we talked about different swellings like thyroglossal cyst. This was accumulation of secretions anywhere in a patent thyroglossal tract. This extends from the foramen cecum at the junction of anterior 2/3 and posterior 1/3 of tongue, right down up to the lower part of the neck. Usually, this entire thyroglossal tract disappears before birth, but if it remains patent after birth, there might be accumulation of secretions leading to a swelling exactly in the middle of the neck. Midline neck swelling, most commonly seen beneath the hyoid bone. Usually in children, this swelling moves with deglutition. Characteristic feature is it also moves with protrusion of tongue because of the attachment with the foramen cecum. This may contain cholesterol crystals, just like branchial cyst and hydrocele fluid. Sometimes this cyst can complicate into infection, abscess can form. If the abscess ruptures into the skin, there is a hole in the skin, and this cyst was actually in relation to thyroglossal tract. So now if it has ruptured into the skin, a fistula has developed between the skin and thyroglossal tract, which we call as thyroglossal fistula. Thyroglossal fistula is never congenital, it is always acquired. Sometimes papillary thyroid cancer can occur in these thyroglossal cysts. The treatment for this should be cyst trunks operation, where we not only remove the cyst or fistula, but we remove the entire thyroglossal tract. Sometimes ectopic thyroid tissue can be found other than the normal location in the lower part of the neck. This ectopic thyroid tissue can be found in the region of the thyroglossal tract. If it is situated on the foramen cecum on the tongue, this is lingual thyroid. If it is situated in the middle of the neck, usually in the upper neck, that is a median ectopic thyroid. Branchial cyst and branchial fistulas. Branchial cyst and fistula both are in relation to vestigial remnants of second branchial cleft. Both are located at the anterior border of sternomastoid muscle. The only difference is the cyst is located in the upper neck and the fistula is located in the lower neck. Cyst is lined by squamous, fistula is lined by ciliated columnar. The internal opening of the branchial fistula is located on the anterior aspect of posterior fascial pillar behind the tonsil, and the treatment for both should be complete excision. Cystic hygroma was a lymphatic swelling in the posterior triangle of neck. During intrauterine life, there are jugular lymph sacs located in the neck, and if they aggregate together, if they collect together, then lymph can get collected in those lymphatic sacs, leading to a swelling. And sometimes the swelling can become so big in size that it can even obstruct labor. Since there is a clear lymph inside, they are brilliantly transluminant, and since this is a vessel, it will be lined by endothelium. The treatment should be complete excision. However, we can use sclerosing agents like Picibanil OK432. The most brilliantly transluminant swelling in the body is cystic hygroma. Other swellings which can transilluminate include ranula, hydrocele, meningocele, and sometimes even the branchial cyst. Chemodectoma is a potato tumor, which is a tumor in relation to the carotid body chemoreceptors at the bifurcation of common carotid artery. In ENT, we read about a potato nose, that is rhinophyma, hypertrophy of sebaceous glands. In ENT, we read something about hot potato voice, that is in peritonsillar abscess quinsy. From the neck, we move down into the thorax, and there we talked about esophageal atresia, that is absence of some part of the esophagus. This was because of posterior deviation of the tracheoesophageal septum. Most commonly, we see a type C, where upper esophagus is blind and the lower esophagus communicate with the trachea. Another type what we can see is H type of esophageal atresia. Here, the important thing is it is not atresia of the esophagus, but there is just an abnormal relation between the esophagus and the trachea, that is a tracheoesophageal fistula. These esophageal atresia stories can be associated with other problems, other congenital problems, which are remembered by the mnemonic VECTERAL, V vertebral, A anorectal, C cardiac, T tracheoesophageal fistula, R renal, and L limb defects. Cardiac anomalies are usually the commonest anomalies. During intrauterine life, the saliva is not going down. All the saliva will be coming out, and the female would be having polyhydramnios. These esophageal atresias will be presenting at birth with continuous pouring of saliva from the mouth. There is risk of regurgitation, aspiration, and pulmonary complications can occur. Initially, in the labor room itself, we can try passing a nasogastric tube. If that does not go beyond 10 centimeters, it suggests a traffic jam, that is esophageal atresia. We can do the chest x-ray and we can find coiling of the nasogastric tube in the upper esophagus. If we find that the stomach or the intestines are distended with gas, that means that probably there is a associated fistula also where the trachea is communicating with the lower esophagus. Investigation of choice, or the best investigation in these cases, would be CT scan. In the treatment, we want to divide the fistula, repair the trachea, and join the upper and the lower esophagus as esophagostomy. This is done by doing a thoracotomy on day 1 or day 2 of life. If suppose before the operation on CECT we come to know that upper and lower esophagus are far from each other and we won't be able to join, there's no point of doing a thoracotomy. In these cases, we wait for 4 to 6 weeks time, allow the two ends of esophagus to grow, and then we reassess. During this waiting time, we give the nutrition through feeding jejunostomy. After 4 to 6 weeks, if the two ends of esophagus come close, we can do a esophagostomy. But if they remain far, we just mobilize the stomach and do the esophageal reconstruction. Dysphagia lusoria is simply compression of the esophagus by aberrant right subclavian artery leading to dysphagia. Compression of esophagus can also be done by double aortic arch or the right aortic arch. In the abdomen, epigastric stories, duodenal atresia. This is absence of some part of the duodenum due to failure of fusion of foregut with the midgut. The baby will present with bilious vomiting within few hours after birth. This is the commonest cause of intestinal obstruction in a newborn baby. It is the commonest GI anomaly associated with Down syndrome. Overall, the commonest cause of intestinal obstruction in all ages, it is post-op adhesions. Now, when we take an X-ray in these babies, we can find a double bubble sign. We understood the concepts. If there is pyloric obstruction, we find a single bubble. If there is duodenal obstruction, we find a double bubble. If there is jejunal obstruction, we find a triple bubble. If there is a ileal obstruction, we find multiple bubbles confined in the central part of the abdomen. If there is large intestinal obstruction, we find multiple air fluid levels in the peripheral part of the abdomen. In the treatment of this duodenal atresia, we can simply connect the proximal and the distal duodenum, that is duodenal-duodenostomy, that is the treatment of choice. If by chance the two ends of duodenum are far from each other, then we do a duodeno-jejunostomy. Annular pancreas is something where there is ring of pancreatic tissue which surrounds the duodenum and create the same type of situation. On X-ray, we'll find the same double bubble sign, and the treatment would also be the same, duodeno-duodenostomy, and the alternative would be duodeno-jejunostomy. Hypertrophic pyloric stenosis, congenital or infantile variety. This is hypertrophy of the pyloric musculature. Usually firstborn male child is affected. 2 to 3 per 1000 live births. Presents during 3rd week of life. Can present between 2nd to 6th week. Usually there is olive lump in the epigastrium. This is due to thickened pyloric muscle. We can find a visible peristalsis from left to right on giving a test meal to this baby. Since there is a pyloric obstruction, the baby will present with non-bilious projectile vomiting, where acid is going to be lost. So there will be metabolic alkalosis inside. To compensate for this, urine will try to become alkaline, but if the baby is persistently vomiting for 2 to 3 days, the baby will be getting dehydrated, and then water conservation will become priority. So ADH aldosterone type of hormones will be stimulated, and they'll try to conserve sodium water from the kidney tubules. When sodium is getting reabsorbed, then potassium H ions are excreted in urine. Potassium in urine kaliuresis leading to hypokalemia, H ions in urine, acidic urine. Ideally, the urine should have been alkaline, but it is becoming acidic due to conservation of water. So we call it as paradoxical aciduria. First thing what we need to do in these babies in emergency is to correct the hydration and electrolytes. We can do ultrasound of the abdomen. If the thickness of the pyloric musculature is more than 3 to 4 millimeter and length of pyloric canal more than 16-17 millimeter, it favors hypertrophic pyloric stenosis. In the treatment, initially we can try doing a pneumatic balloon dilatation, but the best results are obtained by surgery, where we do a Ramstead seromyotomy. We are just cutting the serosa and the muscle, so there is no perforation. If by chance accidentally we cut the serosa muscle, submucosa and the mucosa, then it will become perforation. Then we discuss something in right hypochondrium, biliary atrasias, absence of biliary channels. Exact cause is not known, but probably due to inflammatory fibrosis in the biliary channels starting in the first week of life. 3 types: type 1 as CBD, 2 CHD, 3 right and left hepatic ducts. Most common type 3. Whenever the biliary channels are gone, the baby will have jaundice, steatorrhea, malabsorption. First investigation to be done in a patient presenting with jaundice will be LFT. Then we can do the ultrasound to see the biliary channels. In general, we have got 3 options. Best option is MRCP because that is non-invasive. That is magnetic resonance cholangiopancreatography. That is just MRI showing the biliary channels. But MRI cannot be done in small babies because of motion artifacts. Another investigation is ERCP, where endoscopic retrograde cholangiopancreatography. We can see the biliary channels with the help of a contrast. Whenever any diagnostic or therapeutic procedure has to be done, then to pass the instrument for diagnostic therapeutic purpose, we prefer doing a ERCP. But in biliary atrasia, where there are absence of biliary channels, whether it is type 1, 2 or 3, if common bile duct is not there, then even if we are doing ERCP, there is no place to push the contrast. So ERCP is not possible in biliary atrasia. Another investigation what we do is HIDA scan, where we give the isotope in the peripheral vein. It goes through the circulation in the liver, excreted by the hepatocytes into the biliary channels, and then with the help of gamma camera we can see the isotope coming into the biliary channels. That is why HIDA scan is the investigation of choice for biliary atrasia. In the treatment, if it is just a type 1 biliary atrasia, where only CBD is absent, we can request the jejunum and connect the jejunum with the common hepatic duct. That is called as hepaticojejunostomy or a Roux-en-Y hepaticojejunostomy. But in type 2, type 3 biliary atrasias, if suppose there are no biliary channels at all, then we just request the jejunum to get fitted inside the liver at the porta hepatis. This is a Kasai operation, hepaticoportoenterostomy. This will not be able to drain all the bile, and maybe in few months or years, the patient will develop biliary congestion inside the liver and the liver will fail, and eventually we'll have to do a liver transplant. Choledochal cyst is cystic dilatation of the biliary channels. Exact cause is not known, but probably due to anomalous pancreatico-biliary duct junction, there are dilatations in the biliary channels. Todani classified them into 5 types. Type 1, type 2 and type 3 involve the CBD. Type 4 and 5 involve the hepatic ducts. Type 1 is a diffuse dilatation of CBD, which is the most common. Type 2 is dilatation of CBD above the pancreas. Type 3 is dilatation of CBD within the pancreas, which we call as choledococele. Type 4A, which involve both intra and extrahepatic ducts. 4B, only the extrahepatic ducts. 5, only the intrahepatic ducts. Type 5 is called as Caroli's disease. central dot sign corresponds to portal vein in this Carolese disease. These choledochal cysts can present in OPD with painless intermittent jaundice in infancy, sometimes mass in the right hypochondrium. If the patient presents with the jaundice, first investigation LFT. If presents with mass in the abdomen, first investigation ultrasound. For right hypochondrium, especially the gallbladder biliary areas, LFT ultrasound are complementary to each other. We can see the choledochal cyst on ultrasound, but better we can see on ERCP. In the treatment, since we know that choledochal cyst can be associated with various complications like cancer can occur in these cysts, so we cannot take any chances. We need to excise the cyst and then do a hepatico-jejunostomy. Sometimes these choledochal cysts, because of biliary stasis, can complicate. Stasis can lead to infection, acute inflammation of the biliary channels, cholangitis. Patient will present with high-grade fever, chills and rigors, severe pain in the right hypochondrium, and jaundice. Pain, fever, jaundice, Charcot's. Sometimes this can complicate. The bacterial party in the CBD can go into the blood, which may lead to septicemia. Pain, fever, jaundice, hypotension, mental confusion is Raynaud's mentard. This is an emergency situation where we are focusing to save the life of the patient, so we give basic resuscitation, IV fluids, IV antibiotics. We do a quick LFT ultrasound and we can do endobiliary stenting, ERCP and stenting. Various complications which we have come across: cholangitis, cholelithiasis, that means stones in the biliary ducts, cholelithiasis, stones inside the gallbladder. Cholangiocarcinoma can occur most commonly at the confluence or hilum of right and left hepatic duct, called as hilar cholangiocarcinoma or Klatskin's tumor. Klatskin's tumor. Intussusception is invagination of one part of intestine into the adjacent part. Whenever some part of the intestine becomes heavy, peristalsis can force that heavy part of intestine to ride into the adjacent part. Most commonly, this is a ileocholic intussusception seen at around 6 months of age, maybe 5 to 10 months of age, due to hypertrophy of Pierce patches. Up to 6 months of age, the baby is taking exclusive mother's milk. After 6 months, when top feed is given, the baby's intestine can develop infections, because of which the lymphoid follicles, Pierce patches situated in the wall of the terminal ileum, can swell up, and that will facilitate this intussusception. This, what we are seeing, is a ileocholic intussusception. Why we are saying this as ileocholic? Because here we can notice the appendix on the side. In adults, polyps in the colon can cause colocholic intussusception. Usually the presentation in intussusception, the sausage lump in the right hypochondrium may be seen in the left side also in the paraumbilical region, but concavity of the lump will be directed towards the umbilicus. Sometimes mucus and blood and stools, red currant jelly stools. When we clinically examine these babies, because the ileocecal region has moved up into the right hypochondrium, when you palpate the right iliac fossa, you may find emptiness in the right iliac fossa, and that is what we call as dance sign. When we do a digital rectal examination, the examiner's finger may be stained with blood. If the baby is presenting with a mass in the abdomen, then we do an ultrasound, donut sign, X-ray crescent meniscus sign. Barium enema, we see a claw sign and a coiled spring sign. This is something which is very important for our image-based questions. We can see a nice claw. In the treatment, we want to reduce the intussusception, so hydrostatic reduction is preferred by using air enema. We can use saline and barium enemas also. If hydrostatic reduction by enema fails, then we have to do operative reduction, where we never pull but always push, gentle milking of the outer tube in order to reduce the inner tube. If the involved segment is gangrenous, then we have to reset the gangrenous segment and do an end-to-end anastomosis. In the lumbar region, the kidney area, absent kidney, incidence 1 in 1000. This is due to renal agenesis, but the other kidney would be normal. Ectopic kidney, when the kidney has not reached into the lumbar region, it is arrested in the lower abdomen itself. If the kidney fails to ascend, it will be lying in the pelvis in the retroperitoneum. Most often this is seen on the left side. Again, the patients do not have any problem. The kidneys, both the kidneys may be absolutely normal. Polycystic kidney disease. This can be congenital or infantile. Congenital is also called as adult because it manifests after 30 years of age. Congenital adult is autosomal dominant, while infantile is autosomal recessive. It is much rare and is associated with high mortality. So what we see as a doctor in clinical practice is the congenital or adult variety presenting after 30 years of age. Usually we see multiple cysts in both the kidneys, so it's a bilateral condition. It may be associated where the patient may be having cysts in other organs also, like liver most commonly, maybe spleen, pancreas and the ovaries. It may be associated with berry aneurysm of circle of Willis and mitral valve prolapse. Because of multiple cysts in both the kidneys, there will be swelling and pain in bilateral lumbar region. There can be hematuria, hypertension in 75% and uremia. In our clinical approach for swelling in the lumbar region, we do the ultrasound, and ultrasound can tell us about these multiple cysts in both the kidneys. Best investigation would be doing a CECT. If we are doing any contrast study like IVU, IVP, then we see spider leg appearance. Initially, we can try doing decompression of the cyst by removing the capsule, deroofing of the cyst. But eventually, because of the cyst, the nephrons are totally compressed, kidney fails, and we have to do a kidney transplant. If we are doing a kidney transplant, left kidney is preferred from the donor because of long length of left renal vein. The transplanted kidney is placed in the iliac fossa because we have to anastomose the donor renal artery and vein with the recipient vessels. Iliac vessels have got a bigger caliber, so the results of vascular anastomosis would be better if we are anastomosing them with bigger caliber vessels. Liver transplant is generally an orthotopic transplant because the transplanted liver is placed in the same anatomical region in the right hypochondrium. Various contrast studies of GI tract for esophagus swallow, stomach meal, duodenum, jejunum, ileum, meal follow through, and colon enema. Various contrast studies of the urinary tract, upper tract, lower tract, upper tract kidney ureter, IVU, IVP, that is intravenous urography or intravenous pylography. We can also do antegrade, retrograde pylographies. Lower urinary tract, bladder, urethra. For bladder, we are doing a cystogram or cystography. For urethra, we are doing a retrograde urethrogram. Micturating cystourethrogram or voiding cystogram is useful in two conditions: posterior urethral valve and vesico-ureteric reflux. Horseshoe kidney, the incidence is 1 in 900. During intrauterine life, when both the kidneys are ascending upwards, both the kidneys, they look at each other and they start feeling for each other. There is a possibility that they might try to come close to each other, and sometimes their lower poles can fuse. Now when the kidney is ascending, the inferior mesenteric artery may stop the ascent of these two kidneys, and this isthmus will be lying at L3, L4 vertebral level, preferably the L4 vertebral level. Usually patients are asymptomatic. Sometimes there might be some symptoms. There may be swelling and pain in the lower abdomen. UTI, stone formation can occur. In the treatment or in the investigations, if the patient is presenting with swelling and pain in the lower abdomen, first investigation would be ultrasound, best would be CECT. When we are doing a contrast test study, then we can see a flower vase uretus or the hand joining sign. In the treatment for UTI, we give antibiotics. For stone, we just remove the stone. Division of isthmus is not the treatment of choice because if you are making an incision on the parenchyma, it can bleed profusely. So unless and until it is mandatory, we avoid it. In the iliac fossa, we talked about a diverticular story, the Meckel's diverticulum. Before that, if we take a look, that during intrauterine life, there is a connection of the umbilicus with the intestine, which is called as vitellointestinal duct. There is connection of the umbilicus with the bladder, which is called as allantois or future urachus. Generally, this entire connection obliterate before birth. So after birth, there is no connection of intestine or bladder with the umbilicus. Sometimes, if this connection remains patent after birth, then intestinal contents start coming out from the umbilicus, that is umbilical fecal fistula. If the allantois remains patent, then urine may start coming out from the baby's umbilicus, that is a umbilical urinary fistula. Sometimes only the umbilical end may be patent, the intestinal end would have closed, and then mucus would be coming out from the umbilicus, that is the umbilical sinus. The same thing can happen towards the bladder also. Another story, if suppose only the intestinal end remains patent, but the umbilical end has closed, then this is an intestinal diverticula. Same thing with the bladder. If vesical end is patent, the umbilical end is closed, this is a bladder diverticula. These are congenital diverticulas, true diverticulas, because they contain all layers of the organs. This is called as Meckel's diverticulum. This should be differentiated from diverticulas seen in elderly people. As we grow older, the tissues become weaker and weaker. Whenever there is any traffic jam type of situation, the proximal people are going to get dilated, pressure in the proximal part will increase, and if the wall of the proximal part is weak, this pressure will force the mucosa to protrude outwards. Constipated individuals, fecal matter impacted in the rectum, high pressure in the sigmoid forces the mucosa of the sigmoid to go out, sigmoid colon diverticulars. Tone of cricopharyngeal sphincter tight, high pressure in the pharynx, wall of the pharynx weak, will force the mucosa of the pharynx to protrude outwards through the Killian's dehiscence, Zenker's diverticulum. These acquired diverticulars are false diverticulars. They do not contain all the layers. They are commonly seen in elderly people. Meckel's diverticula, it is the persistence of the intestinal end of vitellointestinal duct. Meckel's is found on the anti-mesenteric border. Anti-mesenteric border. It has got its own blood supply and follows the rule of 2% population, 2 centimeter wide, 2 inches long, 2 feet proximal to ileocecal junction, presents at around 2 years of age, and 2% of patients are symptomatic. It consists of heterotopic epithelium, most often gastric epithelium. Pancreatic colonic epithelium can also be found. If it is found in the hernial sac, it is called as a Lichter's hernia. Usually Meckel's is asymptomatic. If present with symptoms will mimic symptoms of acute appendicitis. Complications can occur in Meckel's, most commonly bleeding. Diverticulitis, diverticular perforation can occur. Peptic ulcer, intussusception can occur. Intestinal obstruction can occur. This is because of a band from the umbilicus to the apex of diverticula. Best investigation here is a Meckel's scan, which is a radioisotope scan, technetium pertechnetate scan. Other investigations can be barium meal follow-through and video capsule endoscopy. In this radioisotope scan for Meckel's, it identifies the gastric epithelium. If the patient is asymptomatic, no treatment, but if the patient is having symptoms or complications, narrow mouth Meckel's, diverticulectomy, wide mouth Meckel's, resection of segment of intestine bearing the Meckel's, followed by end-to-end anastomosis. And we prefer using the staplers. Iliac fossa, left side Hirschsprung disease, also called as congenital megacolon or congenital aganglionosis. This is due to absence of ganglion cells in the nerve plexus, most commonly rectosigmoid area where rectum is always involved. Depends on whether a small segment or a long segment is aganglionic. If only a small segment is aganglionic, the story will not present immediately after birth. As the baby grows in childhood, when this aganglionic segment increases, the baby might suffer from constipation, and to diagnose this, we can take a suction rectal biopsy. We can do manometry for high pressures in the rectum sigmoid area. We can do a barium enema to know the exact length of the aganglionic segment. On barium enema, the contracted segment is aganglionic while the dilated segment is normal. If a long segment is aganglionic, then immediately after birth, the force of the peristalsis above will not be sufficient to force this fecal matter to pass through such a big aganglionic segment. So there will be fecal impaction here, proximal dilatation, and this increases the risk of perforation. This is an emergency condition. We can simply do a proximal colostomy. In short segment disease, we can do Duhamel, Swenson, Sovin-Park coloanal anastomosis. In the hypogastrium, duplication of renal pelvis and ureter. This is the commonest congenital anomaly of upper urinary tract. In duplication of renal pelvis, we can find a drooping Lilly sign. What Lilly sign is seen in hydrated cyst? In duplication of ureter, there is a Mayer-Wegert law. If there are two ureters, then usually both the ureters join so that only one ureter is left which opens into the bladder normally. Sometimes, if there are two ureters, they do not join, and in this case, the lower ureter opens normally in the bladder, but the upper ureter passes distally and open more medially, which is called as ectopic ureter. Most common site of ectopic ureter in males is the apex of trigone. It can open in the seminal vesicles or prostatic urethra. Patient presents with recurrent UTI. In females, the ectopic ureter opens distal to the distal sphincter, presents with dribbling urinary incontinence. We can do IVP-IVU for confirmation, and treatment should be ureteric reimplantation. Ureterocele is simply partial atresia of the ureteric orifice. Usually it is bilateral, common in females, seen in childhood with UTI. On IVP-IVU, find cobra head or adder head appearance. Cobra head or adder head appearance. In the treatment, we can do an endoscopic longitudinal incision of the ureteric orifice, which can result in complication like vesico-ureteric reflux. And to demonstrate vesico-ureteric reflux, we do a micturating cystourethrogram. In the urethra and penis, posterior urethral valves, they are found only in boys. This is pathological. They are found in the prostatic urethra just distal to the virum montanum. Depending on completeness of the valve, if they are incomplete, then the story will present in OPD in childhood with recurrent UTI. Investigation of choice would be micturating cystourethrogram. If the baby is having problems, then we have to do a transurethral resection or fulguration of the valves. If the valves are complete, then the story will present in the newborn baby with retention of urine, and for that you have to do an immediate urethral catheterization. If you're not able to negotiate the catheter, then you put a catheter from above, suprapubic cystostomy. Hypospadias is a condition where the external urethral opening is not present at the normal location but present anywhere on the undersurface of penis. This is the commonest congenital anomaly of male urethra. Incidence is 1 in 200 to 300 male live births. Most common being the glandular, least severe being the glandular. No treatment for glandular. Most severe is perineal, least common is perineal. Sex is difficult to differentiate in perineal type of hypospadias. Use of diethylstilbestrol has been found to be associated with hypospadias. In hypospadias, because of absence of urethra distal to the ectopic urethral opening, there is a fibrous cord which causes downward curvature of the penis, that is chordae. The patient will have problems in urination, erection, and sperm deposition. For this, correction has to be done. Surgical correction, chordae correction, and urethral reconstruction, urethroplasty, ideally done at 10 months of age. If staged operation is done, it is done between 6 to 18 months of age. For urethroplasty, we use prepuce. Prepuce is the skin which is covering the glans. If prepuce has to be used for urethral reconstruction, then circumcision should not be done. Circumcision is removal of the foreskin which is covering the glans. Circumcision is something customary religious in Jews and Muslims. If the baby is having hypospadias, circumcision should not be done because we are going to use this prepuce to make the new urethra. Complication of this surgery is urethro-cutaneous fistula. And the last thing, undescended testis or cryptorchidism. This is the commonest congenital anomaly of male genitalia. The incidence is 3% in a full-term baby, 30% in a preterm baby, right side 50%, left side 30%, bilateral 20%. 75% of undescended testis will descend down into the bottom of the scrotum within 3 to 6 months of life. Undescended testis is when the testis is arrested in the normal path of descent. Ectopic when the testis deviate from the normal path of descent. Retractile when the testis has descended normally into the scrotum, but on stimulation, the testis may ascend upwards into the inguinal canal. No treatment is required for retractile testis. Most common site for undescended testis is inguinal canal. Most common site for ectopic testis is superficial inguinal pouch or the Dennis Brown pouch. However, they can be found in the femoral ring, root of the penis, perineum. Complication in undescended testis, remembered by the mnemonic A testis. A atrophy, T trauma, E epidymorchitis, S sterility if bilateral, T torsion, I inguinal hernia, which is the commonest complication, and S seminoma. After clinical examination, if needed, we can do the ultrasound and diagnostic laparoscopy, and the treatment for undescended testis. After 6 months of age, we can do orchidopexy. Generally, this is done between 6 to 12 months of age. Most common malignancy in a young male is testicular cancer, elderly male, prostate cancer, female, breast cancer, rural India female, cervical cancer. Most common cause of testicular malignancy is undescended testis. Most common malignancy in undescended testis is seminoma. Most common testicular malignancy is a seminoma, and most common testicular malignancy in elderly male is a lymphoma. Right. Now, we'll revise this without this workbook. Let's try. Right. Pediatric surgery, the surgical problems in the pediatric age group, starting from top to bottom, the face, cleft lip and palate, swellings in the neck, thyroglossal cyst, branchial fistula, cystic hygroma, chemodectoma, thorax, esophageal atresia, dysphagia, leusuria, abdomen in the epigastrium, duodenal atresia, annular pancreas, hypertrophic pyloric stenosis, right hypochondrium, biliary atresia, choledochal cyst, intussusception, lumbar region, absent kidney, ectopic kidney, polycystic kidney, and horseshoe kidney, right iliac fossa, Meckel's diverticulum, left iliac fossa, Hirschsprung disease, hypogastrium, duplication of ureter and uretrocele, urethra, posterior urethral valve, hypospadias, scrotum, undescended testis. In the face, this cleft lip and palate. Most common congenital anomaly of the orofacial structure is combined cleft lip and palate, 45%, cleft palate alone 40%, cleft lip alone 15%. Cleft lips are more common on the left side. Reason, genetic, environmental factors like maternal epilepsy. If the mother is taking some drugs during pregnancy like phenytoin, diazepam, and steroids, Pierre-Robin syndrome, isolated cleft palate, retrognathria, and posteriorly displaced term glossoptosis. Cleft lip can be diagnosed on antenatal ultrasound after 18 weeks of pregnancy. If the baby is born with cleft lip and palate, there will be problems in airway, breathing, swallowing, dentition, and speech. We need to do surgical correction. Cleft lip, 3 months, 3 to 5 months, Millard-Wardell operation. cleft palate, soft palate 6 months, hard palate 12 to 15 months. Neck swellings, thyroglossal cyst. This is due to accumulation of secretions in a patent thyroglossal tract, which usually obliterate before birth, but if it persists after birth, then secretions can get collected anywhere right from the foramen cecum, which is at the junction of anterior 2/3, posterior 1/3 of tongue, to the lower part of the neck, that is isthmus of the thyroid. However, most commonly it is seen beneath the hyoid bone in children, exactly in the midline, presenting with a midline neck swelling, which moves with deglutition, and characteristic feature, it also moves with protrusion of tongue. It may contain cholesterol crystals like branchial cyst and hydrocele. Sometimes complications can occur, infection can occur, abscess can form which can rupture and become a thyroglossal fistula, which is never congenital, it is always acquired. Papillary thyroid cancer can occur. The treatment should be not only excision of the cyst or fistula, but complete excision of the thyroglossal tract, and this is called as Sistrung's operation. Ectopic thyroid tissue is simply presence of thyroid tissue somewhere else other than the lower part of the neck. It may be present on the foramen cecum on the tongue, lingual thyroid. It may be present in the upper neck, median ectopic thyroid. Branchial cyst, branchial fistula. Both are remnants of second branchial cleft. Both are situated at the anterior border of sternomastoid muscle. Cyst in the upper neck, fistula in the lower neck. Cyst by squamous, fistula by ciliated columnar epithelium. The internal opening of the fistula is located at the anterior aspect of posterior fascial pillar behind the tonsil. The treatment for both cyst and fistula is complete excision. Cystic hygroma is a sequestration or accumulation of the lymphatic sacs in the posterior triangle of neck. Since clear lymph is present here, this is brilliantly transluminant. These cysts may enlarge during intrauterine life, and sometimes they can even obstruct labor. These are lymphatics, so they will be lined by endothelium. The treatment should be complete excision. Sclerosing agents like Picibanil OK-432 have been given for the treatment of cystic hygromas. It is the most brilliantly transluminant swelling in the body. Other transluminant swellings can be ranula, meningocele, hydrocele, and rarely even branchial cyst. Chemodectoma or potato tumor is a tumor originating from the chemoreceptors at the carotid body where the common carotid artery bifurcates. Potato nose is rhinophyma, hypertrophy of sebaceous glands. Hot potato voice, peritonsillar abscess is quinsy. In the thorax, esophageal atresia is absence of some part of the esophagus, most often due to deviation of the tracheoesophageal septum posteriorly. Most common type of esophageal atresia where the upper esophagus is blind and the lower esophagus communicate with the trachea is tracheoesophageal fistula. Another type which we can see is H type, where there is no atresia as such, but just an abnormal connection of the esophagus with the trachea, isolated tracheoesophageal fistula or H type of fistula. The esophageal atresias can be associated with congenital anomalies here and there, which are remembered by the mnemonic VECTERAL, V for vertebral, A anorectal, C cardiac, T tracheoesophageal fistula, R renal, L limb defects. Most common the cardiac defect. During pregnancy in esophageal atresia, there will be polyhydramnios. How they will present to us? Immediately after birth, you will find continuous pouring of saliva from the baby's mouth. There are chances of regurgitation, aspiration, and pulmonary complications. You can do the initial evaluation bedside test by putting a nasogastric tube. If it does not go beyond 10 centimeters, there's a traffic jam. You can take the X-ray. On X-ray, you will see coiling of the nasogastric tube in the upper esophagus. If on X-ray you find gas in the stomach or the intestine, that means it is also associated with fistula of the trachea with the lower esophagus. Best investigation would be CECT, and the treatment should be division of the fistula, repair of the trachea, and esophagostomy by doing a thoracotomy on day 1 or day 2 of life. If before operation by CECT we come to know that the upper lower esophagus are far from each other, We wait for 4 to 6 weeks, give feeding jejunostomy. After 4 to 6 weeks, we reassess. If the two ends have come close, we do esophagostomy. If the two ends still remain far, then we mobilize the stomach and do the esophageal reconstruction. Dysphagia lusoria. Lusoria is a specific term used for aberrant right subclavian artery. Compression of the esophagus by aberrant right subclavian artery is dysphagia lusoria, which leads to dysphagia. Compression of the esophagus can also be done by other vessels like double aortic arch or a right aortic arch. In the abdomen, in the epigastrium, duodenal atresia is absence of some part of the duodenum due to failure of fusion of foregut with the midgut. The baby will present with bilious vomiting within few hours after birth. This is the most common cause of intestinal obstruction in a newborn baby. Overall, the commonest cause of intestinal obstruction is postoperative adhesions. Duodenal atresia is the most common GI anomaly associated with Down syndrome. When we take the X-ray, duodenal obstructions, we see double bubble sign. Whether it is duodenal atresia or annular pancreas, we see the double bubble sign. Pyloric obstruction, single bubble. Duodenal obstruction, double bubble. Jejunal obstruction, triple bubble. Small intestinal obstruction, multiple bubbles in the central part of abdomen. Large intestinal obstruction, multiple bubbles in the peripheral part of the abdomen. Bubbles or the air fluid levels, that is one and the same thing. In the treatment of duodenal atresia, we are simply doing a duodenectomy. But if the two ends of duodenum are far from each other, then sometimes we might have to do a duodenojejunostomy. Annular pancreas is a ring of pancreatic tissue which surrounds the duodenum. Can present same as duodenal atresia, X-ray double bubble sign, treatment duodenectomy, alternative duodenojejunostomy. Hypertrophic pyloric stenosis, congenital infantile, hypertrophy of the pyloric musculature. This is not atresia, this is stenosis. Takes some time. Usually firstborn male child is affected, 2 to 3 per thousand live births. Commonly presents during 3rd week of life. Can range from 2nd to 6th week of life. Presents as an olive lump in the epigastrium, and this lump is because of the thick pyloric muscle, not the distended stomach. When we give a test meal to this baby, we see vigorous peristaltic movements moving from left to right. The baby is presenting with projectile non-bilious vomiting, which will lead to vomiting of acid. So there will be metabolic alkalosis inside. The kidneys will try to throw the alkali out. Initially, the urine will be alkaline. But since the baby is continuously vomiting, the baby will get dehydrated. And because of this dehydration, the kidneys will try to conserve sodium in water. Sodium will be reabsorbed. Potassium and H ions will be excreted in urine. Potassium in urine, kaliuresis, hypokalemia. H ions in urine, acid in urine, paradoxical aciduria. First thing to be done in these babies, rehydrate, electrolyte correction. Once the baby becomes stable, then ultrasound, thickness of pyloric muscle more than 3 to 4 millimeter, length of pyloric canal more than 16-17 millimeter favors pyloric stenosis. Treatment initially, we can try doing a pneumatic balloon dilatation, but the best results are obtained by surgery, Ramstedt seromyotomy, where we cut longitudinal incision, cutting the serosine, the muscle of the pylorus. Right hypochondrium, biliary atresia, absence of biliary channels. Exact cause is not known, but probably due to inflammatory fibrosis starting within the 1st week of life. 3 types: type 1 CBD, type 2 CHD, type 3 left-right ducts, most common type 3. If there are no biliary channels, jaundice, steatorrhea, malabsorption, hepatomegaly. First investigation to be done in a patient presenting with jaundice is LFT. First investigation in a patient presenting with MAS would be ultrasound. Here we are doing a LFT. Ultrasound and LFT are complementary to each other in the biliary pathologies. To see the biliary channels, the best investigation overall should be MRCP, that is non-invasive, but MRCP, MRI is not possible in small babies because of motion artifacts. If we have to do any diagnostic therapeutic procedure in the biliary channels, Then we do ERCP, endoscopic retrograde cholangiopancreatography. We pass an endoscope from the mouth right into the duodenum, and through the side channel of the endoscope we can pass some instruments and do some diagnostic therapeutic procedures. ERCP is not possible in biliary atresia because whether it is type 1, type 2 or type 3, there is no common bile duct, so we will not be able to put the contrast anywhere. So for biliary atresia, the only option left is HIDA scan. It is a radioisotope scan, radiation. This isotope is excreted by the hepatocytes, goes into the biliary channels. In a normal person, within 60 minutes, all this isotope is cleared from the liver and biliary channels into the intestine. If there is biliary atresia, the isotope will get arrested there and will be able to see and classify the type of biliary atresia on HIDA scan. In the treatment, if it is type 1 biliary atresia where only CBD is gone, that means common hepatic duct is there, we connect the jejunum with the common hepatic duct, hepaticojejunostomy. If type 2, type 3 biliary atresia is there where there are no biliary channels, suppose, then we directly put the jejunum into the liver at the porta hepatis, hepaticoportoenterostomy, Kasai operation. This Kasai operation will not be able to drain all the bile from the liver. Eventually, biliary congestion will increase inside the liver over a period of months and years, and maybe in 1 year, 2 years, the liver will completely fail and eventually we'll have to do liver transplant. If we don't treat biliary atresia babies, these babies will die within 3 years of life. Choledochal cyst is a cystic dilatation of the biliary channel. Exact cause is not known, but probably it is due to anomalous pancreatico-biliary duct junction. Todani classified this into 5 types: 1, 2, 3 CBD, 4, 5 hepatic ducts. Most common type 1, diffuse dilatation of CBD. Type 2, eccentric dilatation of CBD above the pancreas. Type 3, dilatation of CBD within the pancreas, called as choledococele. 4, 4A, 4B, 4A, dilatations involving the intrahepatic and extrahepatic ducts. 4B, dilatations only extrahepatic ducts. 5, dilatations only intrahepatic ducts. 5 is also called as Caroli's disease. Center dot sign in Caroli's disease corresponds to portal vein. How this choledochal cyst can present to us? Small baby in infancy, there may be biliary stasis in these choledochal cysts, which can lead to painless intermittent jaundice in infancy and sometimes a mass in the right hypochondrium. The baby may come to us in OPD. We do a LFT if the baby is presenting with jaundice, ultrasound if the baby is presenting with mass. On ultrasound, we'll be able to see the cyst in the biliary channel. Best investigation to see the choledochal cyst would be ERCP, and in the treatment, we don't want to take chances with these cysts because they can become cancer. So we do a cyst excision and do a hepaticojejunostomy. Sometimes these choledochal cysts can complicate, like cholangitis. If there is stasis in the biliary channels, party time, E. coli party, acute inflammation of the bile duct, cholangitis, high-grade fever, chills and rigors, severe pain in the right hypochondrium, jaundice, pain, fever, jaundice, Charcot's. This can complicate. Bacteria may go into the blood causing septicemia, leading to hypotension and mental confusion. Pain, fever, jaundice, hypotension, mental confusion, Raynaud's pentad. This is a dire emergency situation where the patient has gone into septicemia, patient is dying. You do the basic resuscitation, get a quick LFT ultrasound done if that is available, and try to reduce the septic load from CBD by doing a endobiliary stenting, ERCP and stenting. Once the life of this patient is saved, then you have got plenty of time to think when you have to do cyst excision and hepaticojejunostomy. Complications in choledochal cysts can be cholangitis. Stones can form in the biliary channels, choledocholithiasis. Cancer can develop in the biliary channels, cholangiocarcinoma. Cholangiocarcinoma most often develops at the confluence of the right and left hepatic duct. Hilar cholangiocarcinoma, Klatskin's tumor. If the stones are developing inside the gallbladder, we call that as cholelithiasis. Whenever some part of the intestine becomes heavy, peristalsis forces that part of intestine to move into the adjacent part, leading to intussusception. Most commonly seen at around 6 months of age, 5 to 10 months, ileocolic intussusception due to hypertrophy of Pierce patches. Till 6 months of life, the baby is on exclusive mother's milk. After 6 months, when top feed is given to the baby's intestine may develop infections, and Pierce patches, which are the lymphoid follicles situated in the wall of the terminal ileum, can get hypertrophied, and because of that, there will be heaviness in the terminal ileum, and peristalsis will force the terminal ileum to move into the cecum, ileocolic intussusception. We can also find this intussusception in adults, maybe because of polyps in the colon, colocolic intussusception. In intussusception, we can find sausage lump in the right hypochondrium or maybe in the left paraumbilical region. The concavity of the lump is directed towards the umbilicus. Blood and mucus in stool, red currant jelly stools. When we examine these babies, because the ileocecal region has moved up into the right hypochondrium, there is emptiness in the right iliac fossa. Empty right iliac fossa is called as sign of Tans sign intussusception. When we do our digital rectal examination and take out the finger, the examiner's finger is stained with blood. If the baby presented with a mass, we do ultrasound donut sign, X-ray crescent meniscus sign, barium enema claw sign, coiled spring sign, best investigation CECT, treatment hydrostatic reduction, where we give the enema with a force. Air enema, saline, barium can be used, but air enema causes minimal injury and intussusception is reduced most of the times. If this is not successful, we do operative reduction, where we gently milk the outer tube in order to reduce the inner tube. We never pull in intussusception. If by chance in intussusception we find that the area is strangulated or gangrenous, then we have to do resection of the gangrenous part and do an end-to-end anastomosis. In the lumbar region, we talked about absent, ectopic, polycystic, and horseshoe kidney. Absent kidney, 1 in 1000 due to renal agenesis, other kidney normal. Ectopic kidney, 1 in 400. If the kidney fails to ascend upwards, it will be arrested in the pelvis in the retroperitoneum, usually left-sided. Polycystic kidney disease, congenital, infantile, congenital, also called as adult because it manifests after 30 years of age. This is autosomal dominant. This is more common. Infantile, autosomal recessive. This is rare and associated with high mortality. So what you will see in your clinical practice would be a congenital adult polycystic kidney after 30 years of age. It is bilateral. Both the kidneys are having multiple cysts. It may be associated with cysts in other organs, most commonly liver, spleen, pancreas, ovaries. We can find cyst. It may be associated with berry aneurysm of circle of Willis, may be associated with mitral valve prolapse. When there are multiple cysts in both the kidneys, there can be swelling and pain in bilateral lumbar region, hematuria, hypertension 75%, and uremias. In our clinical approach, if there is swelling in bilateral lumbar region, we do ultrasound and we can come to know about these cysts. Best would be CECT. If we are doing a contrast study like IVU, IVP, we find spider leg appearance of the calyces because calyces are compressed by the cyst. In the treatment, initially we can try doing a de-roofing of the cyst for decompression, but eventually these cysts will damage the nephrons completely, kidneys will fail, and we'll end up in doing a kidney transplant. Usually we prefer left kidney from the donor for transplant because of long left renal vein. When we are doing kidney transplants, the transplanted kidney is placed in the iliac fossa, that is at a different anatomical location than the lumbar region. This is called as heterotopic transplant, and this is because when we have to anastomose the renal artery and renal vein, we want good diameter vessels, good caliber vessels, iliac vessels. This gives better results of anastomosis. In liver transplants, we are keeping the transplanted liver in the same anatomical location, and that is called as orthotopic transplant. Various contrast studies which can be done for GIT, esophagus, swallow, stomach, meal, duodenum, jejunum, ileum, meal, follow through, colon, enema. Urinary tract, upper urinary tract, kidney and ureter, IVP, IVU, intravenous pyelography, urography. We can also do antegrade, retrograde pyelography. Lower urinary tract, bladder and urethra. For bladder, we do cystogram, cystography. Urethra, we do a retrograde urethrogram. We can do a micturating cystourethrogram or a voiding cystogram for vesicoureteral reflux and posterior urethral valves. Horseshoe kidney. When the kidneys become like horseshoe, 1 in 900. When the kidneys are ascending upwards during intrauterine life, they look at each other, they try to come close to each other, and there is a possibility that there might be fusion of medial subdivision of the lower poles of the two kidneys. And when they are ascending upwards, inferior mesenteric artery can stop their ascent, and this isthmus is arrested at L3, L4 level. L4, better answer. Usually patients are asymptomatic, but sometimes swelling and pain in the lower abdomen, not in the lumbar region. Urinary tract infection stones can form. In the investigation for swelling and pain in the lower abdomen, we do ultrasound. We can see that both the kidneys are located in the lower abdomen only. We do a CECT as the best investigation, and there we can see this horseshoe kidney nicely. If we are doing a contrast study, IVP, IVU, we find flower vase ureters, hand joining sign. The treatment for UTI, antibiotic, stones, removal of the stones, division of isthmus is not the treatment of choice because it can lead to severe bleeding. Unless mandatory, we avoid dividing the isthmus in horseshoe kidney. In the right iliac fossa, we talked about the diverticular stories. We discussed something about the intrauterine life. There is a connection of the umbilicus with the intestine and connection of umbilicus with the bladder during intrauterine life. Connection with the intestine is called as vitreointestinal duct or omphallomesenteric duct. Connection with the bladder is called as allantois or the future uricus. Normally, both these connections of the umbilicus, they completely obliterate just before birth. But if by chance they persist after birth, if connection of umbilicus with the intestine persists after birth, intestinal contents will come out from the baby's umbilicus, umbilical fecal fistula. If allantois persist after birth, urine from the bladder will come out from the umbilicus, umbilical urinary fistula. Sometimes only the umbilical end remains patent, the intestinal end or the vesical end closes. In these cases, only mucus will come out from the baby's umbilicus. This is umbilical sinus. Sometimes the intestinal part remains patent, umbilical part closes. This is intestinal congenital diverticula or a Meckel's diverticula. Sometimes only the vesical end remains patent, the umbilical end closes. This is a congenital urinary bladder diverticula. Whether it is Meckel's or congenital urinary bladder diverticula, these are true diverticulas as they contain all layers of the organ and they are present right from birth. This should be differentiated from acquired diverticulas in elderly people. As we grow older, the tissues become weaker and weaker. Whenever there is any traffic jam situation, the proximal pupil will be dilated. The pressure in the proximal part will be high. Whenever the pressure in the proximal part is high, if the wall of the proximal part is weak, then pressure will force the mucosa of the proximal part to move out as acquired diverticula. This concept can be applied in the colon, like in constipated individuals when the fecal matter remains in the rectum for a long period of time. This causes dilatation in the sigmoid colon. High pressure in the sigmoid colon can force the weak mucosa of sigmoid colon to move outwards, acquired sigmoid colon diverticulas. If the tone of the cricopharyngeal sphincter is too tight, pressure in the pharynx will be high. High pressure in the pharynx can force the weak wall of the pharynx to protrude outwards, usually through the Killian's dehiscence, resulting in Zenker's diverticulum. These acquired diverticulas are false. As they do not contain all the layers, they usually contain only mucosa and superficial submucosa, and they are commonly seen in elderly people. Regarding Meckel's diverticulum, this is a congenital true diverticula. All layers of the intestine are present. It is found at the antemesenteric border. It is the patent intestinal end of the vitellointestinal duct. It has got its own blood supply. It follows the rule of 2% population. 2 centimeter wide, 2 inches long, 2 feet proximal to the ileocecal junction, presents at around 2 years of age, and 2% can be symptomatic. It contains heterotopic epithelium, most commonly the stomach epithelium or the gastric epithelium. Even pancreatic colonic epithelium can be found in Meckel's. If Meckel's is found in the hernial sac, it is called as a Litter's hernia, usually asymptomatic. If symptomatic, mimics appendicitis. Complications can occur in Meckel's like bleeding, most common, diverticulitis, diverticular perforation, peptic ulceration, intussusception, and intestinal obstruction. Intestinal obstruction is due to a band from the umbilicus to the apex of Meckel's. To diagnose these Meckel's, the best thing is Meckel's scan, which is a radioisotope scan, technetium pertechnetate scan, where the isotope is taken by the gastric epithelium. We can do barium meal follow-throughs and video capsule endoscopies. In the treatment, if the patient is asymptomatic, nothing has to be done. Symptomatic or complicated Meckel's, depending on the mouth of the Meckel's, if it is narrow mouth, diverticulectomy, wide mouth, resection of segment of intestine bearing the Meckel's, and end-to-end anastomosis. In the left iliac fossa, Hirschsprung disease, congenital megacolon, congenital aganglionosis. In this, there is absence of ganglion cells in the motor nerve plexus, most commonly in the rectosigmoid area where rectum is always involved. In adults, there is absence of ganglion cells seen in the esophagus, that is an ecclesia cardia. Here in Hirschsprung disease, depending on the length of aganglionic segment, if only a small segment is aganglionic, the story will present later in life in childhood with constipation. We can do a suction rectal biopsy to make the diagnosis. We can do anorectal manometry to assess the pressures in the rectum sigmoid area. We can do barium enema to know the extent of the aganglionic segment. If on barium enema we see that narrow contracted segment, that means that is aganglionic or pathological area. The proximal segment, which is normal, will be dilated. In the treatment for this Hirschsprung, we can do Duhamel, Swenson, Sovent, Park, coloanal anastomosis. Sometimes, if a long segment is aganglionic, then the story presents immediately after birth in the newborn baby in the neonatal period. Complete traffic jam situation. The force of peristalsis is not sufficient to push the fecal matter through a big long aganglionic segment, so the fecal matter gets impacted. A complete traffic jam in the large intestine. The proximal large intestine gets dilated, and the baby presents with gross distension of abdomen. This is a dire emergency, and we have to decompress by doing a proximal colostomy. Later on, once the life is saved, when the story is saved, once the baby becomes stable, then we can think of doing definitive operations, resections for these Hirschsprung. In the hypogastrium, duplication of renal pelvis and ureter is the commonest congenital anomaly of the upper urinary tract. Usually we know that we all have got 2 kidneys, and in each kidney we have got 1 renal pelvis and 1 ureter. But sometimes God can give 2 renal pelvis or maybe even 2 ureters on one side. If there are 2 renal pelvis, then sometimes the upper pelvis is small because it drains only the upper moiety, while the lower pelvis is large because it drains the middle and lower moieties. If there is obstruction at the upper pelvic-ureter junction, the upper pelvis becomes dilated, and then it puts pressure on the lower pelvis, and the lower pelvis starts drooping down. That is a drooping lily sign. Water lily sign is seen in hydrated cyst. In case of duplication of ureter, if God has given 2 ureters, most often these 2 ureters join so that there is only 1 ureter which is opening into the bladder. But rarely there is a possibility that the 2 ureters may not join. In such case, the lower ureter may be opening normally in the bladder, but the upper ureter may pass distally and open more medially than its counterpart. This is called as ectopic ureter. Most common site of ectopic ureter in males, apex of trigone, prostatic urethra and seminal vesicles are the other sites. These males present with recurrent urinary tract infections. In females, the ectopic ureter most often opens distal to the distal sphincter, and then this female will present with dribbling urinary incontinence. IVPIU makes the diagnosis, and the treatment is whosoever has gone out of his home, we have to just pull the ears and put it back into the normal location, that is ureteric reimplantation. Ureterocele is a partial atresia of ureteric orifice which causes dilatation of the intramural part of the ureter. This is usually bilateral, common in females seen in childhood with UTI. When we do a IVPIVU, we find a cobra head or adder head appearance. In the treatment, we can do a endoscopy, that is cystoscopy, and make a longitudinal incision, cut the ureteric orifice. The complication can be vesicoureteric reflux, which can be diagnosed by micturating cystourethrogram. In the urethra, posterior urethral valves, these are something which can be seen just distal to the verumontanum in the prostatic urethra, only in boys. This is actually the commonest cause of urethral outlet obstruction in boys. These valves can be incomplete or complete. If they are incomplete, then the story presents later in life in childhood with recurrent urinary tract infection. We can do a micturating cystourethrogram to see the obstruction, or a voiding cystogram, and the treatment would be endoscopic or transurethral resection of these valves or transurethral fulguration of these valves. If by chance these valves are complete, it will produce a complete traffic jam. Immediately after birth, the newborn baby will present with retention of urine. This is an emergency situation. We can relieve this by putting a urethral catheter from below into the bladder, or if this urethral catheterization is not possible from below, then we can put a suprapubic cystostomy. Hypospadias, when the external urethral opening is not present at the normal location but is present anywhere on the undersurface of penis, that is hypospadias. If it is present on the upper surface of penis, that is epispadias. Epispadias is very rare. Hypospadias is very common. It is the commonest congenital anomaly of male urethra. The incidence is 1 in 200 to 300 male live births. This can be classified based on the site of external urethral opening: glandular, coronal, subcoronal, distal penile, mid-penile, proximal penile, penoscrotal, scrotal, perineal. Opening which is more near to the normal will be more common and less severe. Opening which is far from the normal will be less common and more severe. So out of the given varieties, glandular will be the most common and least severe. No treatment is required for glandular. However, perineal will be the most severe and least common. In perineal hypospadia, sex is difficult to differentiate. Consumption of diethyl stilbestrol during pregnancy has been associated with hypospadias in the baby. In hypospadias, the urethra distal to the ectopic urethral opening is absent, and that is represented by a fibrous cord, which is a hard cord and puts pressure and causes downward curvature of penis. That is chordee. Because of this chordee, the baby will have problems in urination, later in life problems in erection and deposition of sperms, which are serious issues, need correction. Surgical correction, what we can do is, we can simply remove that fibrous cord, chordee correction, and do a urethral reconstruction, urethroplasty. Ideal age 10 months, but can be done between 6 to 18 months if it is a staged operation. For doing urethroplasty, we commonly use prepuce. If you are using prepuce, that means in Jews and Muslims, where circumcision is done for customary religious reasons, should not be done. After urethral reconstruction or urethroplasty, a common complication which we see is a urethrocutaneous fistula. The undescended testis or cryptorchidism, we know this is the commonest congenital anomaly of male genitalia. The incidence of this undescended testis is 3% in a full-term baby. That means 3 out of 100 male babies born will be born with undescended testes. Preterm babies, the incidence goes as high as 30%, right side 50, left 30, bilateral 20%. But the best part is 75% of undescended testes descend down to the bottom of the scrotum within 3 to 6 months of life. Undescended testes means the testes are arrested somewhere in the normal path of descent. Ectopic means when the testes deviate from the normal path of descent and come to lie somewhere else. Retractile testis means the testes have actually descended normally into the bottom of the scrotum, but maybe if somebody is trying to scratch the skin of the medial aspect of thigh, that is trying to elicit the cremasteric reflex, because of contraction of the cremasteric muscle, the testis may be pulled up into the inguinal canal. But when you examine these babies, if you are able to bring the testis from the inguinal canal down to the bottom of the scrotum, they are not undescended or ectopic, they are just retractile. No treatment is required for retractile testis. Undescended testis, most common site is the inguinal canal. Ectopic testis, most common site is the superficial inguinal pouch or the Dennis-Brown pouch. However, ectopic testis can be found in the femoral ring, root of penis, perineum. Complication in undescended testis are remembered by the mnemonic A testis, A for atrophy, T trauma, E epididyma or chitis, S sterility if bilateral undescended testis, T torsion, I inguinal hernia, which is the commonest complication of undescended testis, and S seminoma. Most common cancer developing in undescended testis is seminoma. Most common cause of testicular cancer is undescended testis. February 23, when you are examining these babies, careful clinical examination is very important. You can do ultrasound, and if you are not able to see the testis on ultrasound, you can take the help of diagnostic laparoscopy. The treatment should be bring the testis down to the bottom of the scrotum and fix to the bottom of the scrotum. Ideally should be done at 6 months or maybe after 6 months, 6 to 12 months of age. So this is all about the pediatric surgery. Thank you very much for your patience, Pita. God bless you all. Wish you all the very best. Just remember one thing, that you are here for a purpose. You know that you are already putting in hard work, dedication. Let all these things do not go in vain. Come what may. Let us keep on pushing ourselves as hard as possible, as hard as possible, as hard as possible. And let us just think one thing, that yes, we have to do it. And yes, we can do it. This is very much possible. I'm able to understand the stories. Yes, I'm able to grab the things. Why not? I will do it. Who the hell on this earth can stop me in reading this and revising this, in practicing this? I will do it. I'll make my parents proud. I want to see the happy tears in my parents' eyes on 17th of December and 31st of December. Thank you very much. God bless you. Wish you all the best. Thank you once again for your patience. The house is open for any queries. Just a moment, I think. Let us Can we discuss the pediatric surgery questions, as I'm receiving few requests? Okay, so what we'll do is we'll discuss the pediatric surgery questions in the workbook. Right, beta. So this looks to be a little lengthy question. Let us read the last line of the question first. Which of the following metabolic abnormality most likely in this baby? Let us see the options. Hypokalemic, hypochloremic, metabolic alkalosis. Then hypokalemic, hyperchloremic. In these type of options, we might confuse ourselves. So let us just try to split these words. Metabolic, alkalosis, 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 and there is one thing, acidosis. So one, what we have to rule out, whether it is alkalosis or acidosis. Now another thing here, hypokalemia, hypokalemia, hyperkalemia. So we have to see whether it is hypokalemia or it is hyperkalemia. Okay, so we have to focus on potassium. Then hypochloremia, hyperchloremia, hypo. Okay, so we have to look for chloride. Let's see what is the story. 17-day-old projectile non-bilious lump in the epigastrium, more prominent when baby was breastfed, vigorous peristalsis from left to right, rehydration electrolyte correction. Okay, so this is a clear-cut case of pyloric stenosis, and we know in pyloric stenosis what is happening? The acid is getting lost, so there will be metabolic alkalosis, number one. Since there is HCl, so chloride will be getting lost, so there will be hypochloremia, number two. And now what happens in the kidney when sodium in water is getting reabsorbed, then potassium is getting lost in urine, so there will be low potassium. Now we have to just find these three and let us forget rest everything. Right. So here in alkalosis, okay, so this is gone. Now potassium low. Potassium low, there are two options. That means this is gone, this is gone. Now chloride low. So out of this is gone. So the answer is simple. Now again a lengthy question. Found to have hypokalemic, hypochloremic, metabolic alkalosis. That means something similar type of picture. Pyloric obstruction. He is most likely suffering from. Okay, 55-year-old male, right, has presented with repeated episodes of epigastric pain for the last 3 years, which initially were relieved with PPIs. Okay, so he is talking about some peptic ulcer disease. Later on, he also took eradication for H. pylori. He is not getting relief. For the last, he is having non-bilious. He is not giving history of significant weight loss. Moral of the story, there is no significant weight loss which is mentioned. So this is not cancer. Now, all these diseases, we can find this hypochloremic, hypokalemic, metabolic alkalosis. How to differentiate? This, you know, this is 3rd week of life. So here in the given question, it is 55. So let us rule this off. Now gastric cancer and peptic ulcer, 55-year-old, both can occur. If it would have been gastric cancer, it would not have been relieved with PPI and there would have been weight loss. So we can rule this gastric cancer out and the answer would be peptic ulcer. Now treatment of choice for congenital abnormality presenting few hours after birth with bilious vomiting due to failure of fusion of foregut with midgut. So this is, he is simply asking duodenal atresia. What is the treatment? Answer should be duodenodudenostomy. Preferred investigation of choice, 10-day-old baby suffering from biliary atresia. Now, if there is biliary atresia, we know HIDA scan is something what we are doing. We are not doing MRCP because it's a small baby. The small baby will keep on moving on the MRI table and there will be motion artifacts on the screen and we will not be able to see anything. ERCP is not possible in biliary atresia because there is no CBD. So we cannot push the contrast anywhere. So here the answer will be HIDA scan. Patient presented with discharge of urine from the umbilicus. Patient otherwise appears to be healthy. What can be the likely cause of this condition? So urine coming out from the umbilicus, what we discussed was the patent allantois. That means failure of involution of Omphalo? No, this would have been fecal discharge. Yes, failure of involution of allantois, that should be the right answer. Image-based question. This is a intussusception, the ileocolic intussusception. Now let's look at the option. Will be doing emergency appendicectomy? No. Resection of segment of pathological and followed by end-to-end anastomosis. In intussusception, if it is gangrenous, then we do this. Saline enema, air enema. So looking at the question, we feel that examiner is just asking what is the treatment of choice. So the answer should be this. But let me read the question. 6-month infant, sausage lump right hypochondrium, blood mucus stool, dance sign positive, CECT thick distal ileum, commonly adopted treatment. Answer is air enema. This is an image-based question, and here we can see these are the two laddus. So this is a cobra head, adder head appearance. Now if we take a look, the answer should be uretrocele. Anything else he is asking? No. So it is very clear. The answer should be uretrocele. Again, image-based question. This is Meckel's diverticula. It is found on the antemesenteric. Yes. It is a congenital true diverticula present since birth. Yes. Meckel's scan is a double contrast barium enema. No. Meckel's is a radioisotope scan. It consists of heterotopic gastric epithelium. This is true. So probably he is asking what is not true, which is incorrect. Okay. So we have to be careful. Incorrect. Yes, we know. This is not a double contrast barium enema. This is a radioisotope scan. Newborn baby with empty scrotum. Testis lying close to the peritoneum. Now, newborn baby, undescended testis. We cannot manually bring the testis down because this is lying close to the peritoneum. That means behind the inguinal canal. Cold compresses, this will also not help. Ideally, if we take a look, then generally we see that by 3 to 6 months of life, 75% of the testis can descend spontaneously. So in this particular case, there is nothing like that. Now we have got two options, GnRH and testosterone. The studies have shown that both GnRH and testosterone can help. A better help can be obtained with GnRH. So we go ahead with this GnRH, which may stimulate the testicular descent. 7 months old infant, male, brought by his parents to OPD with the complaint that mother is not able to feel the testis in the baby's scrotum since birth. 7 month, testis not felt. Right testis was felt in the bottom of the scrotum, left was felt in the left inguinal canal. Most probable diagnosis and treatment in this baby. Right testis, bottom of the scrotum, that means normal. So right testis, no treatment is required. Left testis, left inguinal canal, that means undescended testis, so we need to do orchidopexy. Right undescended, no. Right is normal, left is undescended, left orchidopexy. So this should be the answer. Right ectopic, left undescended, bilateral undescended. Right. So these type of questions are commonly being framed by the examiners. Right. Now just let me just have a look if there is any query left out, though I am able to answer all the queries. Right, beta. So I don't see any queries as such. If there is any, I'll respond directly on WhatsApp. Thank you very much, beta. Thank you for your patient listening. May God bless you.